All right. Assalamu alaikum, everyone. I hope you're all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais, and today, inshallah, I'll be covering the second part of the MSI crash course. And inshallah, for this one, I'll be covering the entirety of dermatology. So, similar to my session yesterday, inshallah, today I'll be covering everything in dermatology, and more specifically, I'll talk about dermatopathology and infectious diseases. So, a lot of micro, inshallah. The other disciplines are a bit minimal because the most important things are just those two. And similar to my session yesterday, it will be very interactive. And in fact, this time, inshallah, we're going to focus a lot on the images, okay? Because the key of dermatology is just identifying images. Okay, if you know how the disease presents as in terms of the image and some tips with the presentation, then that's it. You master dermatology, basically. But differently than my sessions before is I'm going to explain a lot of derma on one slide, and then we're going to go over each disease. So without further ado, we will begin. The first thing is just this slide, okay? We're going to be talking about a lot of diseases just from this one slide. So firstly, just the basics. Now we have two layers of a skin, okay? We have this layer and then this layer, big layer. What is this bottom layer called? Again, interactive. Dermis. Good. Now, what is this other layer called? The second one, or the more superficial one? Epidermis. Simple. Okay. So now we'll talk about the dermis first and some important concepts about the dermis. Now, which of these two layers will have blood vessels? Dermis or epidermis? Dermis. Good. So the dermis will actually have a lot of blood vessels and it'll have a lot of collagen. And this is important is because these blood vessels, what will come out of the blood vessels? Firstly, of course, blood. And second thing is white blood cells, okay, inflammatory cells. So in any case of inflammation, there is always going to be white blood cells that are coming from the dermis and then going upwards. Why? Is because the epidermis does not have any blood vessels, okay? The blood supply comes from the dermis. So in any case where you have an infection and inflammation, it will start from the dermis and move upwards. Okay, that's the key thing about the dermis. The other thing is gonna be these projections of the dermis into the epidermis. What do we call this? Dermal papilla. Good. So dermal papilla, the one significant thing about this is if it goes too deep into the epidermis, it will basically tell you that the dermis is too close to the surface of the skin. So if you scratch the skin, you're gonna expose the dermis, which has blood. Okay? The key finding of this is in a certain disease, and we'll talk about this later. Okay? That's that for the dermis. These two important points: dermal papilla and the blood vessels, which will come, what will come out of the blood vessels? Inflammatory cells. Okay? Now, between the dermis and epidermis is this interface, okay? Now, what will hold the epidermis to the dermis? What will anchor the epidermis to the dermis is it desmo or hemidesmosomes? Hemidesmosomes, good. Okay, hemidesmosomes, okay? This is very important because if you have separation of the hemidesmos of the epidermis from from the dermis, this is a defect in hemidesmosomes, okay? Now we'll go into the epidermis. So the epidermis has 5 layers, okay? So the first layer is this bottom layer. What is this bottom layer called? Stratum basale. Good. From the name itself, it's the basal layer, okay? Now the basal layer will basically, when you have new skin to develop, it will start from the basal layer and move upwards, okay? Where you have new keratinocytes, which are the cells of the epidermis. If it's developing, it's going to start at the level of the stratum basale where you have all the basal cells, which is all stem cells, and then we'll go upwards, okay? So that's concept number one. Concept number two is you have certain other cells that are located in the stratum basale, which are these pigmented cells. What are these cells? Melanocytes. Good. Melanocytes contain pigment, which is melanin, which is responsible for darker skin, okay? Now, Melanocytes, when they grow, they usually grow horizontally, which is along the basement membrane between the dermis and epidermis. Okay? What do we call this spread of melanocytes, which is along the dermal epidermal junction? Not radial. Radial is vertical. The actual dermatologic term is lentiginous. Okay? This is important to remember. Lentiginous. Lentiginous growth means that the melanocytes are growing sideways, okay, or proliferating sideways, okay? This is kind of important to remember that term, okay, because of certain diseases. Now, the second layer is called what, which is up to here, before that, which is the thickest part, is the spinosum. Good. Stratum spinosum, which contain keratinocytes, okay? Now, what will basically join the keratinocytes together? What will hold them together? Desmosomes. Good. Okay. Now, let's just say you have a disease that will break the desmosomes. This will cause separation of the keratinocytes, mainly in the stratum spinosum, because it's this layer. What do we call this finding? Separation of the keratinocytes because of desmosomes. Acantholysis. Good. Perfect. Okay. Then the next layer, which is this layer, which will have these darker cells. What do we call this layer? Stratum granulosum. The only thing you need to remember is these cells are just dark, and this layer is called the stratum granulosum. Okay? The finding of what changes here, I'll explain in a bit. Then we have this small little layer, which is not clinically important, but it's called stratum lucidum. Good. Now, how about this layer, last one? Stratum corneum, which contain dead or alive keratinocytes. Dead keratinocytes. Good. Do they have nucleus? Yes or no? Or nuclei? No. Good. Okay. Perfect. This is the basics of derm. Okay. These layers, anything that affects these layers is a pathology. Okay. Or anything that affects us is a pathology. Now let's just say, we'll start down here and move up. Okay. Is if these blood vessels are located in the dermis, white blood cells start getting released from this. If it goes and causes inflammation of the dermal epidermal junction, this is what we call interface dermatitis. Okay? If the blood cells, the white blood cells, gets released from the blood vessels and moves up to the epidermal dermal junction, this is what we call interface dermatitis. Okay? Now, what if these blood vessels go into the epidermis? What do we call this finding? Excellent. Exocytosis. So, when WBCs go to the dermal epidermal junction, we call this interface dermatitis, where it's basically inflammation of the junction between the dermis and epidermis. If it moves further beyond that into the epidermis, this is what we call exocytosis. Okay, good. Now we go over here. What if you have thickening of all layers of the epidermis? What do we call this? All layers, mainly the spinosum. Acanthosis. Good. Acanthosis is thickening of all layers of the epidermis, mainly the spinosum, which is this middle layer, okay, or the main layer. What if you have increased thickening of the corneum only? What is this called? Hyperkeratosis. Okay, where is the keratin mainly? Dead keratin, and it's in the corneum. So if the corneum itself, stratum corneum, increases in thickness, you'll have hyperkeratosis. Good. What if you have hyperkeratosis with retained nuclei in the corneum? What do we call this? Parakeratosis. Good. Okay. If you have retained nuclei with hyperkeratosis in the stratum corneum, again, the stratum corneum is dead keratinocytes. You don't have any nuclei. If you have retained nuclei, this is parakeratosis. Good. Now, what if you have dead keratinocytes here in the stratum spinosum? What do we call this? This is what we call not Savat bodies. That's different. That's okay. I can see why you answered that. But my main point is abnormal keratin here. The dead keratin should be here. What if it's over here? The proliferation happened here. This is what we call dyskeratosis. And I'll show you an image later. Okay? This is an important finding seen in tumors. Later on, we'll talk about. Then we have this layer. This layer, if it increases in thickness, what do we call this? Which is the stratum granulosum. Hypergranulosis. Good. Okay, so these are the main terms in dermatology that you need to remember. Now, another thing is we have three cell lines typically here. Okay, now I say three because it's just better to differentiate it for you guys. Number one, we have melanocytes. Number two is we have basal cells. Number three is keratinocytes. If we have a tumor of keratinocytes, what type of cancer is this? Squamous cell carcinoma. Good. Basal cells, basal cell carcinoma. Melanocytes, melanoma. Good. Okay, perfect. So that's that. Now, there is another cell that is located inside the epidermis, which are called Langerhans cells. These cells are responsible for antigen presentation. Okay, what will it do is they're located in the epidermis. They go down to the dermis, and then they will go to lymph nodes. They present the antigen to the T cells, which then turn into mature T cells. So when you have re-exposure of any of the antigens that causes any of the pathologies, there will be an inflammation in the second exposure. Okay, which is the basis for a lot of, for example, the atopic diseases such as eczema. Okay, so that's basically the dermatology basics in one slide. Okay, now this is just explaining again all the layers. Is everything till now clear? The last part, I'll explain it in the next slide. Okay, so we have this cell, okay, or this slide. Now we have one cell in this layer, which is called again the Langerhans cells. This cell, what's it's responsible for, it's an antigen presenting cell. Okay, so once you have, for example, exposure to an antigen, let's just say this antigen was pollen. Okay, again, it's mostly asthma that causes, or pollen causes asthma, but let's just say it's pollen or dust. Now, what happens is the first time it gets exposed to it, the Langerhans cell will go to the dermis and then go through the bloodstream, or not the bloodstream, the lymphatics, go to the lymph nodes, and then exposes that antigen or presents that antigen to T cells. What will T cells do? Differentiate into mature T cells. Then the T cell will go back to the dermis. Okay? Second time you're exposed to dust. Okay? Again, Langerhans cells will see this, will come back to the dermis, present it to the mature T cells that are located here, and this mature T cells will now start to cause inflammation, which is the basis of atopic diseases, such as eczema or allergic dermatitis in general. Okay? For that person who asked about the last part, is this clear now? Yes, the mature T cells is in memory T cells, yes. Now, now, now we're going to talk about a lot of microscopic and macroscopic terms. What's more important for you is you need to know the microscopic terms very well. Why? Is because you yourself need to describe it when you see an image on histology. You need to describe it, okay? And we'll practice that with a lot of diseases, inshallah. So we already explained majority of these, but however, just for a repetition, we have dyskeratosis, abnormal premature keratinization. As I said, this is seen in squamous cell carcinoma, which is a cancer of keratin. Okay. Hyperkeratosis, we explained in detail. We explained. Hypergranulosis, we explained. Spongiosis, I'll show you an image of it later, obviously. But basically, if you have fluid buildup around the cell, Okay? Intercellular spaces. Around the cell, this is what we call spongiosis. What's the other point of it is if you have fluid inside the cell, intracellular. What do we call this? Intracellular accumulation of fluid. Hydropic changes. Good. Which is fluid buildup inside the cell. Can you tell the difference on image? There is one image that explains both of these. That image, you cannot tell the difference, in my opinion. However, when I show you specific pathology, such as atopic dermatitis or eczema, you'll see the spongiosis very clearly. Now, acantholysis, as I said, is separation of epidermal cells. This is more specific to pemphigus, and I'll explain what that is in a bit. But if you have anything that affects the desmosomes, this will cause acantholysis. Pemphigus is a key disease that causes it. But however, there's others. Then we have acanthosis, which is epidermal hyperplasia, mostly of the spinosum, and this is seen in a lot of diseases. Now we'll go through it one by one, okay? And you need to identify what's happening. In this case over here, what are the changes that's happening in this tissue? You can tell inside the cell there's a lot of swelling. So what do we call this? Inside the cell, there's swelling. Hydropic changes. Good. Around the cells there's swelling. What do we call this? Spongiosis. This image describes them both. Okay? Will you get this image and get both of these choices? That's crazy if that happens. Okay? But anyways, now over here, what's happening with this tissue? You can see that there is, number one, hyperkeratosis. But what's more evident is, can you see nuclei in the stratum corneum? Yes. So this is parakeratosis. Good. Now this is something that I did not describe to you guys, but what if you have ballooning of the keratinocyte? What do we call this? Vacuolization. Good. Now, vacuolization is not going to be described to you guys in detail in this block. However, this is important later on. This is important in repro, and someone already mentioned, mashallah, this is a very crucial finding of HPV, which is something that we call coilocytic changes. Again, you don't need to worry about vacuolization. Just remember this one image in case it comes in an OSPE question, and you know that this is vacuolization. Okay? This is commonly seen with viral infections, more specifically, human papillomavirus. Okay? Again, forget about the pathogenesis of vacuolization or everything. Just remember just this one image. The rest you need to describe and know what diseases are associated with perikeratosis, spongiosis, which we'll explain in detail. Okay? Now, how about over here? You have this blood vessel, which you can clearly tell. There's a lot of white blood cells, which are all these lymphocytes, you can tell, going into the epidermis. What do we call this? Exocytosis. Good. Okay, perfect. Over here, let's go step by step. Firstly, can you see the basal layer of the epidermis? Yes or no? Yes. What happened here is acantholysis. What's the defected in acantholysis? What caused acantholysis? Breakdown in desmosomes, not hemi, desmosomes. Okay? If it's hemidesmosomes, this basal layer will no longer be there. It will also be elevated. Another thing is you can see floating cells, which are keratinocytes, which is also called acantholytic cells. Okay? Why? Is because, again, this disease is of desmosomes, which means that the attachment of keratinocytes in the epidermis is no longer there. So they're going to start separating from each other. In a case of a disease of a hemidesmosome, okay, the entire epidermis will be together. It will be intact. There's no acantholysis. Okay? This is seen in bullous pemphigoid. Yes. Okay, and we'll talk about this in detail later. Now, how about over here? You have thickening of a lot of layers. And more specifically is this layer. And what if you have hyperkeratosis? Good. Okay? Hyperkeratosis. In the case of acanthosis, the whole thing will be elevated. Here you can see markedly that the corneum is very proliferated. Okay. Now over here is you have premature keratinization in the spinosum. What do we call this? Dyskeratosis. Good. Again, what cancer is associated with dyskeratosis? Squamous cell. Good. How about here? You have the granulosa cell or granulosum layer is increased. What do we call this? Hypergranulosis. Easy. Okay. Now over here, you can see that the melanocytes are growing laterally, proliferating laterally. What do we call this? Lentiginous spreading. Now, how can we tell these are melanocytes? We can use a dye. Does anyone know what this dye is? S100. Good. Okay. S100. Perfect. Good. Okay. Remember this dye. Now over here, we have finger-like projections. What do we call finger-like projections in pathology? Papilloma. Okay. Or papillomatosis, which is what's described here. Now, what is a papilla? You need to describe it like this. Finger-like projections with a fibrovascular core. This core of the papilla is vascularized. It needs to be described like this. If it's described to you like this, then you can say, okay, this is papillomatosis. Okay? Now here is just a picture describing acanthosis for you, not for you to guess, but it's increased thickness of all layers. Okay? And you can clearly tell the difference here than here is because the layers isn't really thickened. It's a normal sized epidermis. However, the stratum corneum is very thickened. Hence, it's hyperkeratosis here. Here, it's acanthosis. Everything is thickened, and more specifically, is the spinosum itself. It's very thickened. Okay? Is everything till now clear? Because if you understand all of this, this will make the rest of this crash course very easy. So, now, dyskeratosis. Okay. So, dyskeratosis. How does keratin proliferation occur? It starts here and slowly goes up, right? The keratinocytes don't really die or mature until they're over here, where they start to lose their nuclei, they start to die. If they die in the spinosum, or not die, I don't want to say die, but if they prematurely turn into mature keratin here, which is very pink, which is a keratin, this is what we call dyskeratosis. Does that make sense? Because this change should happen here, not here. Okay? Now, exocytosis is basically here you have blood vessels. The dermis has blood vessels. What comes out of the blood vessels? WBCs in the case of inflammation. These WBCs will go up to the epidermis. If it goes into the epidermis, as you can see some lymphocytes here, these very dark nuclei over here, this is what we call exocytosis. You're not supposed to see this in the epidermis. If it involves the epidermis, this is what we call exocytosis. Does that make sense? So now we'll go over macroscopic terms. The goal from this is just for you to understand when I tell you, for example, a bunch of papules, when I tell you a wheel, when I tell you a scale, a crust, it just makes it easier for you to understand what I'm saying. Okay, when I'm describing certain lesions of the skin. When you need to identify, oh, this is a papule or a macule, maybe from the images that I'll show you in the next slides. Okay, but just one or two in a like it's a very clear image. That's number one, and number two is they'll mention a size. Okay, so you just need to memorize the size differences when I tell you what's a macule versus a patch. So let's start with this. Is firstly, you have two flat lesions that you need to remember, which is a macule and a patch. What's the difference between them? 5 millimeters. If it's less than 5, macule. More than 5, patch. That's it. These are flat lesions. Okay. Now, if it's elevated lesions, we have either a papule, a macule, or a plaque. Okay? A papule is an elevated lesion less than 5. If it's more than 5 or a bunch of papules, it's a plaque. A macule is more than 5. Okay? However, if it's a bunch of papules together, it's a plaque. Okay? Hence why it says on first aid it's more than 5. Okay? Obviously, this is changed numbers. Yes, it's raised and flat. Okay? In first aid, it's 1 centimeter. However, your slide say 5 millimeters. Go with the slide. Okay? 5 millimeters. Now, what if you have, let's just take a papule that's has a lot of fluids inside. This is what we call a blister. Okay? Now, blister, there's two big major types: vesicle, bulla. Okay? Vesicle, less than 5. More than 5, bulla. Okay? Which is the actual big blister. A pustule is this vesicle that's filled with pus. That's it. Okay? Now, what is a wheal? A wheal is a transient papule or plaque. Okay, a transient, meaning it will show up and it'll go away. This is characteristic for one specific disease, and we'll look into it. Now, a scale is dry, itchy skin. Okay? Where do you see this more commonly is in eczema. Okay? Now, if you have a very dried, brown, honey-crusted lesion, that's what we call a crust. Okay? It's usually described just the same way as I mentioned. Okay? This is seen in one disease, and I'll show you an image of this. Now, just from this slide, you're not going to get much. Now we'll actually just talk about them in terms of images that you need to know. First of all, if it's a flat lesion less than 5, what is this? Flat, less than 5. Macule. Okay. If it's 5, if it's, sorry, a flat lesion more than 5. Patch. Okay. Did I say macule for the papule and plaque? I think I did. I meant nodule. Okay. I meant nodule. Now I realize. So anyways, if you have a raised lesion that is less than 5, what is this called? Papule. If it's more than 5, it's called this thing. Not plaque, nodule. If it's a bunch of papules together, it's called plaque. So remember this. If it's flat, less than 5, macule. Flat, more than 5, plaque. Raised, less than 5, papule. Raised, more than 5, nodule. A bunch of papules together is a plaque. Does that make sense? Again, you don't need to, like in the exam, they will not tell you, is this a plaque or a papule, just from an image. It's just crazy. Okay? So it's just, you might get an OSP question on this. However, it's multiple choices, and then OSP is multiple choice, by the way. And you might get it in a very clear context, or it's something very simple to guess. Okay? Which is, for example, stuff like this. Okay? Again, if it's a raised lesion that has a lot of fluid inside, what do we say this is? It's a vesicle. If it's less than 5, it's a vesicle. What if it's more than 5? It's a bulla. Okay? Which is, for example, this is a big blister. Okay? Now, what if this vesicle is filled with pus? What do we call it? Pustule. Okay? From the name, it has pus in it. Okay? Now, what if it's a transient papule or plaque? Wheal. What disease is characterized as wheals? Urticaria. Hives. Okay? Same thing. Okay? Moving on. We have an eczema patient who keeps itching his skin. What do we call this dry, itchy skin? Scale. The same eczema patient kept itching so much that it became very dry, like this. Not crust. Very dry and gray colored, just to help you. Lichenification. What is lichenification? Is a chronic change to the eczema. Okay? it becomes like the skin lesion itself, it becomes permanent and it turns gray, crusted like this. However, I don't use the term crust. When would I use the term crust? When I'm describing impetigo. Okay? And I'll get to it later. Now, let's just say, same patient who has a scale, you kept itching and it bleeds. What do we call this break of skin over here? Excoriation. Okay? Where it starts to show this red tissue, which is bleed. Now, what if you have this? What do we call the separation of the nail from the nail bed? Onycholysis. Good. Okay? Okay. Perfect. What disease is seen with onycholysis, characterized in onycholysis? Psoriasis. Perfect. Excellent. Okay? Onycholysis is separation of the nail from the nail bed. That's it. Now we have two more. What if you have, obviously it says, but what's the difference between them? Which one involves epidermis only? This or this? Erosion. Erosion is if you have a cut into the epidermis only. If it goes deeper, it's ulcer. Okay? That's it. We finished describing a lot of the skin changes. Okay? And just the normal, or not normal, but basically the terms for dermatology. Is anything unclear till now? Because if you understand all of that, then inshallah the rest of the crash course is easy. So, good. Now we move on to just a bit of immunology, okay? But I've already mentioned this before. Let's just say you have an injury to the skin. What's the first cell that sees this is a Langerhans cell. This is, as I said, an antigen-presenting cell. What will this Langerhans do? If you want to have acute inflammation, what cells are mediated or seen in acute inflammation is neutrophils mainly. So this Langerhans cell will secrete a lot of chemokines and cytokines to attract a lot of inflammatory cells, and this will cause acute inflammation. Okay? Now, what's the important thing about all of this? Is this Langerhans cell, let's just say in atopic diseases, okay, something that you're allergic to, this Langerhans cell will go to the lymph nodes. And as I mentioned, at the lymph nodes, you have a pre-mature or a T cell that then differentiates into a mature T cell. And this T cell, upon re-exposure of the same, let's just say, antigen, will basically cause inflammation. Okay? This is seen in atopic diseases. And we'll talk about which ones in the next few slides, inshallah. Now we will start with the pathologies. You have this patient over here presenting to you with a widespread skin lesions, I'll say papules and plaques. This happened suddenly, and when you took further history, they're telling you that they were eating peanut butter. And it happened. What are the skin lesions seen in urticaria? Wheals, which are transient papules and plaques. Now, good. Urticaria is usually due to what cell being activated? Usually, most of the time. What cell gets activated, releases a lot of substances? Mast cells. What is that substance being secreted? Histamine. Good. So, what happens here is if you have a patient who has anaphylaxis, okay? Anaphylaxis is a severe type 1 hypersensitive reaction. So in this case, the patient is very allergic, let's just say, to peanut butter. This peanut butter is an antigen. It goes and activates let's just say, a B cell, okay? This B cell, I'll say actually in more detail, this plasma cell is responsible for secreting IgE, okay? So this IgE is on mast cells. If you have peanut butter binding to that IgE on the mast cells will secrete a lot of histamine. What will histamine do? Vasodilation. Okay? Vasodilation. So what would happen when you have vasodilation? Elevation of the skin. Because of why is you can tell that this dermis is very inflamed. Okay? There's a lot of fluid buildup in this dermis, which is causing these wheals. Okay? That's why it's a raised lesion. That's why it's a papule or a plaque. Now, is there any changes happening to the epidermis? Yes or no? No. This is crucial to remember. Is in urticaria, you have only involvement of the dermis. Fluid is being extravasated. I forgot the actual term, but basically, fluid is getting released from the blood vessels, going into the dermis. Okay? You might see some inflammatory cells, such as over here as well, immune cells. But the epidermis is normal. Okay? And this is transient. Now, when does urticaria happen? You have four mechanisms. Okay? Now, the most common mechanism is something called mast cell dependent, IgE dependent. What does that mean? Let's just say you have the first time someone gets exposed to an allergen, which is a pollen, let's just say. Okay, common. This B cell will see this pollen and it will bind to this antibody. Okay? Now, this B cell will then turn into a mature plasma cell. When does it do that? Is it when the IgM, which is usually this, class switches to an IgE. And this is due to a lot of cytokines such as IL-4. Okay? It turns into IgE. Now, at this state, the first time you get exposed to pollen, does anything happen to mast cells? The first time you get exposed to it? No, nothing happens. Okay? When is it an issue? Is when you get re-exposed. So let's just say day one, someone went outside. Okay, let's just say they lived in the US, they went outside, it's fall, and they got exposed to pollen or spring. Then they went back inside. Next week, they went outside again, and this pollen will now bind to IgE. When it binds to IgE, this causes degranulation of mast cells. What gets secreted from mast cell? Again, histamine. And histamine causes a lot of things. This is the usual case of urticaria, which is again mast cell dependent, IgE dependent. What's another pathophysiology is something called mast cell dependent, IgE independent. When does this happen? Is when a specific substance binds to mast cell directly, it does not need IgE, binds to it and causes degranulation. This is usually seen in drugs and medications. Then we have another mechanism, which is mast cell independent, IgE independent. So it does not really need mast cells, okay, to cause the vasodilation and the urticaria. There's drugs that cause this, such as aspirin. Why aspirin? And some already mentioned, mashallah. Is aspirin will inhibit this enzyme, which is cyclooxygenase. So what will happen to the pathway? Everything gets shifted to leukotrienes. When you have leukotrienes, you have vasodilation, all these things happening. Hence, urticaria. Okay? The last mechanism is complement mediated, which is seen in, obviously, if you can't inhibit the complement. So you have complement inhibitors, such as C1 inhibitor. If you have a deficiency of that C1 inhibitor, such as in a disease called angiodysplasia, then you have severe widespread urticaria that's usually triggered by a medication. Okay? For 30s, do you remember in CVP which medication causes it? Do you remember ACE inhibitors? Angiodysplasia, like the thickening or their lips swell up so much. Yes, because of bradykinin. Okay. Anyways, this is beyond the scope of this, but just remember that there's these four mechanisms. Okay. That is urticaria. How do we manage urticaria? It's very simple. Antihistamine. Okay. Usually this happens to patients once. It's called spontaneous urticaria. We treat it usually goes away, but if it happens again, due to like we don't know why it happens, and we just treat them with antihistamines. And patients who actually have an allergy to something, then we just treat them with antihistamines, and they carry an EpiPen in case it's anaphylaxis. That's it. Now we have this childhood disease. Okay. And here I will say, okay, you guys answer it. Ala طول, mashallah. It's a very itchy skin lesion that affects the flexor surfaces of in adults and the face of children, which is eczema, which is also called what? allergic atopic dermatitis. Good. Tom, here in this case, it's one of the atopic diseases. So atopic diseases, we have three atopic diseases. One of them is eczema or atopic dermatitis from the name. Atopic means it's allergic reaction. Okay. These patients will commonly also have one of the other two diseases, which is asthma, and number two is allergic rhinitis. Okay. And for second years, you'll learn this in head and neck. But basically, is you have it's type 1 hypersensitivity, IgE mediated and eosinophil mediated. Okay? And it's because of inflammation that happens when you get exposed to something. It's similar to asthma. Okay? If it's asthma affecting the skin, this is atopic dermatitis. What's very important is for you to tell the histology finding. In this case over here, what are you seeing in atopic dermatitis? What's happening in this case? Spongiosis. Good. What's the difference between urticaria and atopic eczema? Is there involvement of the epidermis in urticaria? No. Is there involvement in eczema? Yes. What is the involvement? Spongiosis. Okay? That's basically that. And you can see some interface dermatitis here, which is basically, as I said, inflammation at the dermal epidermal junction. Okay? But this is the most common finding. Now, in children, it usually affects the face, okay? And in adults, it's usually in the flexor surfaces, okay? Now, when it gets, again, when an eczema patients keep itching it and chronic long-term, it turns into this, which is, again, as I said before, lichenification, okay? Now, eczema itself has many stages. So first thing is over here, you can see that you'll have immune cells leaving the blood vessels. Okay, so firstly it involves the dermis. Then you'll have some spongiosis happening and some vesicles, or I don't want to say vesicles, but spaces forming inside the skin. Then slowly, you'll have keratosis, as you can see, some nuclei forming, and hyperkeratosis. Okay, and this is more with a chronic eczema patients because again, because of the itching, continuous itching, it stimulates keratin proliferation. Okay, which is why we see lichenification. But acutely, they will have spongiosis. Okay, chronically, they'll have keratosis, hyperkeratosis. Okay, these are the stages seen in eczema. Now, eczema itself, or allergic dermatitis, there's many forms. The most common is eczema, okay, which is type 1 hypersensitivity. However, you have something like this. What do we call this type of allergic dermatitis, which is contact dermatitis? Perfect. How do you tell the difference? Is there's going to be a clear trigger that's causing localized skin reaction. Localized. The most common way they describe it is someone with a watch. They take off the watch and there's a clear line of inflammation happening. Okay. Why is this so? It's a type 4 hypersensitivity reaction, which is a delayed type reaction. It's T cell mediated. That's also another thing to remember. And it's usually because of a specific antigen. So in the case of watches, it's usually nickel, but anything can cause it, okay? In this case, it's most likely a sandal that the patient was wearing and it caused inflammation here. How do you treat this? Very easy. It's just avoid the trigger, okay? That's it. This is allergic contact dermatitis. What you want to remember is a type 4 hypersensitivity reaction, okay? Now, you have this lesion over here. I'll tell you a case is a patient took medications and then later on developed these lesions that look different. You'll have different papules, macules, plaques. What do you call this? Let's just say it could be aspirin, but let's just say it's antibiotic. There's a lot of drugs. This is erythema multiforme. From the name itself, there's multiple forms to the erythema. Erythema is redness of the skin, okay? And it can present as macules, papules, plaques, whatever, okay? However, something that it's so specific that you need to know is what are these lesions called? Target lesions or targetoid lesions. Excellent. These are targetoid lesions. The center of this lesion is dark red. The periphery is light red. What's the difference is what cell is mediating the center? CD8. What's around it? CD4. 4. Okay, good. Now, how to make sense of this is basically this. Here, let's start from down here. In erythema multiforme, let's just start actually how does erythema multiforme happen? Erythema multiforme is usually a reaction to something. Okay? The actual mechanism into how medications, cancers, inflammatory diseases causes this and infections causes this, we don't know. But it's usually a reaction to something. We have infections that can cause it, and the common infectious link to this is what's it called? We have strep, we also have mycoplasma and HSV. Okay. Then we have cancers, okay, that can cause it. Then we also have other systemic inflammatory diseases that can cause it, okay, such as sarcoidosis. For cancers, yes, I think it's lymphoma as well. And then lastly is medications such as antibiotics, sulfonamides, and some other medications. Okay. So this causes a skin reaction. The skin reaction is mediated by two cells, main cells, CD8 and CD4. Now, what happens is here over here, you see a blood vessel. So the blood vessel, what's going to come out of the blood vessel? Inflammatory cells. So it's going to move upwards. So you'll see interface dermatitis. That's number one. Now, these cells that are initially killing these keratinocytes are CD8 cells. And you can see keratinocytes are starting to die. What are the color of the keratinocytes in this case that are dying? Pink, yellow, red. Not yellow, sorry. Red. Hence, in the center, it's going to be red. Okay, because there are red cells here. Now, slowly later on is that these cells are going to start to separate because they're dying, hence forming this. Okay? Here over here, since it's separating cells, it's going to be a little bit lighter color, which is all mediated by CD4 cells. Why? Is because CD8 are killing these cells and the CD4 are over here. Okay, in the periphery. Okay? The key thing you need to remember is what they will ask you is they will show you this lesion, and firstly, just tell me what is this lesion? Erythema multiforme. Okay. In the case itself, it's usually someone who has one of the risk factors that I mentioned. Either they took a medication, formed these targetoid lesions, very easy to describe, targetoid lesions, or they have sarcoidosis or whatever inflammatory disease they have, then presented with this. And they'll ask you is what's mediating the center necrosis, which is going to be CD8 cells, and what's in the periphery, CD4 cells. This is erythema multiforme in a nutshell. Okay. Now, how about here? Now you have a patient that you gave a medication to. Okay. This medication causes severe blistering everywhere. What do we call this reaction? Stevens-Johnson syndrome. Good. Okay. Stevens-Johnson syndrome is not an infectious etiology. It's a reaction to a medication. Okay. That's basically what you need to know for Stevens-Johnson. Okay. It involves also the mouth. Okay. It forms oral ulcers as well. Okay. So you'll have widespread blisters that form that ulcerate. Okay. Now, what's a more severe form of this is this, which is a more severe Stevens-Johnson syndrome, which is toxic epidermal necrolysis. The actual difference between them, I don't think you need to know, but it's more severe. 10 is more severe. The actual difference is depending on the body surface area. If it's more than 30% excellent, then it's 10. Okay. Usually these patients are very sick, and usually in the clinical scenario, they will mention that they were given a certain medication, okay, and they developed 10 or Stevens-Johnson, okay? That's basically these two diseases. Now you come to this, which is a very common dermatologic disease. Acne, good. Now, what do you see over here? What tells you that this is acne and not any other disease? One word. Comedone. Good. Perfect. If you see comedone, it's acne. Unusual, this like this distribution of acne, it's gonna be either in the chest back, and then the forehead and the face generally. Okay. Now, when does acne present? Usually during puberty is usually the spike of acne, and it's because of hormone. What hormone specifically? If you guys know, androgens. Okay, androgens. Good. Now, what do androgens do? They cause keratinocyte proliferation. Okay. Now, what happens with keratinocyte proliferation is they will start to block the gland. And when you have a blocked gland, you'll have sebum that keeps on increasing. Now, this keratinocyte that's blocking it will get oxidized because of this blockage. Or over here, the sebum will be oxidized. And what will happen is it will turn black. What do we call this? Comedone. Okay? This is a very important thing. What do you need to remember is this is caused usually hormonal. Okay? Now, if this comedone opened up, it'll be a white comedone. And then you'll also have inflammatory acne that usually develops, which is a more severe form. Okay. Now, another thing you need to remember is there a microbe that's associated with acne? Yes or no? Which is called what? This one. Okay. Which is Cutibacterium acne. Okay. Very important to remember. Now, if you want to, if you want to treat acne, what medications can you give them? Keratinolytics, good. Retinoids, antibacterial agents, good. What is the cornerstone of management of acne? What medication? Give me one. Usually given to a lot of patients with acne. Retinoid, okay? But you also have the antibiotics. Now, in real life, we don't usually give them all these medications at once. It's usually a step up depending on the type of acne that they have. Okay, so if you have normal, like mild acne, such as in this patient, we usually give them other medications. We don't give them retinoic acid. We don't give them antibiotics. We usually start with, for example, salicylic acid or benzoyl peroxide. Okay. If they have inflammatory acne, then we start them maybe on topical antibiotics. The last thing we usually give is retinoid. And we usually start with topical, then we go to oral retinoid. Okay, retinoids. Now, what do retinoic acids or retinoids do? There's two forms of it. There's oral, there's topical. Again, we usually start with topical instead of going straight to oral. Oral is usually the last thing we do. Why? Is because of the side effects and the contraindications, which are very important. Now, what do retinoids do? It's in the vitamin A pathway. Retinoic acid is vitamin A. So it causes uh, basically it basically decreases inflammation, decreases the keratinocyte proliferation. That's it in a nutshell. Now, very important about the retinoids is its contraindication. This medication is contraindicated in what? Pregnancy. So usually 3 months before we give patients retinoids, we give them oral contraceptives, okay, to prevent any chances of pregnancy. Why? Is because these medications are severely teratogenic. Okay, that's it about retinoic acid. Other side effects are hypertriglyceridemia, hepatitis as well. But the very important thing to remember is its association in pregnancy. Okay. Now, another medication we can give is antibiotics. We have oral, topical. Again, we start topical, then we go to oral. And the usual topical antibiotic that we use is clindamycin. Okay. If we want to go oral, then we have tetracycline. All right. Now, we also have other medications such as benzoyl peroxide, and this is an antibacterial and keratinolytic effect. And this medication should not be used with the topical retinoid because it basically has an oxidizing effect. Now, I also have other medications such as salicylic acid and so on. Okay. But again, usually the drug that they'll ask you about is retinoic acid. Why? Is because it's very commonly used. However, if they ask you what medication would you want to start the patient on, which they will not ask you, but you can say antibiotics and you're safe. Or you can start saying benzoyl peroxide. If these two didn't work, then you add topical retinoid. If this didn't work, then oral. Last thing is oral. Okay. This is basically acne treatment. Now we'll go to this disease. This patient is a 30-year-old patient presenting to you with these red lesions that affected the extensor, okay, surfaces of their limbs, symmetric, and then they developed into the salmon's colored scale. Okay, what is this disease? Psoriasis. Okay, psoriasis has an autoimmune uh, basically cause or etiology to it. But basically, psoriasis affects usually the extensor surfaces of the joints, so something to differentiate from eczema. Usually is a red colored lesion, which is salmon colored, then turns into the scale, which is a silver-like scale. Okay. Now, severely, it can also affect and turn into this, which is something called pustular psoriasis, which is a very dangerous condition and life-threatening condition. Now, how can you also tell that this is psoriasis? Psoriasis has extra findings. Over here, what do we see in the nail? Onycholysis. This is seen in psoriasis. Now, yesterday, I told you that psoriasis also has an extra dermal manifestation, which is what? Arthritis, psoriatic arthritis. What was the image finding? Pencil in a cup, and they'll form sausage fingers, which is dactylitis. This is psoriasis. Okay? This is usually how they explain it to you. And one other thing, which is high yield, is they'll tell you that last week, okay, or 2 days ago, they had a cut or they got hit on their hand or their arm. Later on, psoriasis developed there. What is this called? Koebner's phenomenon. Good. Nikolsky sign is something completely different. And I'll explain what Nikolsky sign is later. But Koebner's phenomena, again, we don't know why it happens. However, in areas of trauma, the pathology might develop there. Now you guys need to tell me is what type of T cells are associated with psoriasis? T helper 17 and less associated T helper 1. T helper 1 and 17. Remember these two. If you get any immuno question, it's going to be this. Okay? T helper 1 or T helper 17, it's associated in psoriasis. Now, very importantly and very high yield is you need to know the findings in psoriasis. Now, let's start one by one. Firstly is what's happening in the stratum corneum. Is it hyper or parakeratosis? Can you see nuclei? It's very, I know, far, but you can see some nuclei here. As I said, what is the difference between hyper versus para? Parakeratosis is hyperkeratosis plus retained nuclei. So, parakeratosis. Okay? This is parakeratosis. Good. Now, second thing is what's happening to the dermal papilla. It's invading. Okay, you can say papillomatosis. So now, since the dermal papilla is going very deep into the epidermis, okay, if I, let's just say, start scratching right here, what will happen? Bleeding. What do we call this? Auspit sign. Perfect. Why does this happen? Again, what's located in the dermis? Blood vessels. So if you start itching right here, the stratum corneum will go off and you'll have just this very suprapapillary or supradermal thinning, very thin layer. So you can easily cut it and bleeding will occur. Why? Is because the dermis is right there. Okay, you don't have this thick epidermis anymore. Okay, this is auspit sign, high yield. Another thing is, what if you have projections of the epidermis into the dermis? What do we call this? The opposite way. You have dermal papilla here, then you have rete pegs here, or rete ridges. Okay. Now, You will have a collection of neutrophils in the stratum corneum. What do we call this? Monroe's microabscesses. Now, what if you have a collection of neutrophils or pus inside the stratum spinosum or below the stratum corneum? What do we call this? Good. Okay, pustules of Kogok. Good. These five, memorize them by heart. Okay. Parakeratosis, which we identified right here. You can see some retained nuclei over here. Elongation of the rete pegs or rete ridges, which is all of this going down into the dermis. Suprapapillary plate thinning, which is basically elongation of the dermal papilla that causes thinning of the plate or thinning over here. So once you scratch over here, you can bleed, which is called Auspitz sign. Then we have microabscesses, which is collection of neutrophils and pus located in the stratum corneum. This is Monroe microabscesses. Then we have spongiform pustules of Kogok, which is located below the stratum corneum, which is all of this. This is the pustules of Kogok. Are these findings clear to you in psoriasis and how they usually present with? This is a guaranteed question in multiple parts of the exam. MCQ, SAQ, OSPI. Okay? So that is psoriasis. Sure, I'll mention it to you later. If you say parakeratosis, you're correct. Okay? I'd prefer if you say parakeratosis. Why? Is because you do have retained nuclei here, instead of just saying hyperkeratosis. Okay? I'll talk about lichenification later on, inshallah. But you just need to identify it in asthma and again, eczema. Okay? I'll explain it later. Now, psoriasis, how do you manage it? If it's a localized disease, you treat it with topical corticosteroids or immunosuppressant agents such as tacrolimus, or use a phosphodiesterase 4 inhibitor such as romfelumilast. Okay. Then, if it's a more severe disease, you need to go to other agents such as phototherapy. That's number one. Then you have retinoids or immunomodifying agents such as methotrexate, cyclosporin, and other immunosuppressants. Okay. Then we have other medication, which is the topical retinoids, which you might use in psoriasis. Just remember the medication names. However, the chances of you actually getting question about any of these is very minimal. Tazarotene is a retinoid that you can use. Again, it's teratogenic. Then you have immunosuppressants, which is tacrolimus, which are calcineurin inhibitors. We covered some of them yesterday, which will inhibit IL-2, which will decrease T cell activation, basically. Then we have the phosphodiesterase 4 inhibitor, which inhibits phosphodiesterase, which will accumulate cyclic AMP. Okay? The exact mechanism why this actually helps, I don't know. Okay? We don't know. But just remember that we can use these medications in psoriasis. The more commonly medications that you're going to get asked about is retinoids in the context of acne. Okay? It depends. If you have a localized disease, you can just use corticosteroids. You don't need to know which one do you pick. Okay? So now you have this patient. Rosacea. Why is this not acne? No, comedones. Good. Why is this not SLE? Involves nasolabial fold. Good. Perfect. Okay, this is rosacea. Okay. What do we call this? Change to the nose. Starts with R. Rhino something. Rhinophyma. Good. Okay, I think. Okay. Basically enlargement of the nose. Okay, they have this. Basically they have erythematous lesions in the face, and it involves the nasolabial fold. No comedones, and they'll have enlargement of the nose. This is a very crucial sign of rosacea. Okay. That's basically rosacea. All you need to do is identify these features. Okay? If they give you a patient with enlarging nose, involvement of the nose, you think rosacea. Okay? Now you have a patient who is complaining to you that they've been itching their skin a lot and a lot of dandruff is coming. What is this disease? Seborrheic dermatitis. Good. Now, seborrheic dermatitis, from the name, you might say, oh, it's an infection or inflammation of the seborrheic glands, but it's not. It's around it. Okay, and you can see a lot of inflammatory cells that are located around the sebaceous gland. It's not actually affecting the sebaceous gland itself. Now, how does this present as? In infants, it presents as basically a crust lesion that's affecting the scalp. In adults, it's usually of the face and it's typically in the forehead and again the cheeks and the nose. Okay. How does actually how do the patients complain to you? Is they will complain to you of a lot uh of dandruff. Okay. Now there is an infectious organism that is associated with seborrheic dermatitis. It is Malassezia furfur. Okay. Good. Now there's also other systemic diseases that are associated with associated with seborrheic dermatitis, and it's specifically in severe seborrheic dermatitis, which is number one, Parkinson's. Number two is what? Infectious disease. Causes severe immunosuppression, not furfur. HIV. Okay? HIV and Parkinson's are associated with severe manifestation of seborrheic dermatitis. Okay? Because seborrheic dermatitis itself is very easy to manage. However, if they have severe manifestations, then you need to look for underlying diseases, which are Parkinson's. And it's usually because of decrease in dopamine that causes this. The actual mechanism of why decreased dopamine actually causes seborrheic dermatitis. Again, most of the diseases, we don't know why it causes it. And HIV. Again, associated with severe seborrheic dermatitis. Memorize these associations. Okay? Seborrheic dermatitis. Now, we have this patient who's presenting to you with these purple plaques or papules, okay, and affecting the oral mucosa, causing these white lines. What is this disease? Lichen planus. Good. So lichen planus can affect a lot of areas, but it's usually commonly associated with oral cavity, which is this Wickham striaea, which is what we call this. Also in the arms and in the groin as well. Uh, when you go to OB/GYN later on, you'll see this a lot. Now, lichen planus, the high yield thing is how it's described. What is the six things that we look for? There's the six P's. What are the six P's? Purple, polygonal, pruritic, which is itchy, papules, and plaques. There's one more. Okay. Pruritic, purple, polygonal, planar, papules, and plaques. Okay. Which are all these lesions. Again, it usually will be described to you in a patient in a groinal manifestation or in the arms, and typically will affect the oral mucosa, and they'll show you this white involvement, which is, as I said, Wickham striae. Okay. Another thing is, can you see Koebner phenomena in this disease as well? Yes. Okay. Yes, you can. So that is lichen planus in a nutshell. I don't know if this is mentioned to you guys, but lichen planus is also seen or associated with HIV. Okay. And it's a precursor to and hepatitis C, which is very important. Yes. And it can lead to squamous cell carcinoma. Okay, as a risk factor. But good, you mentioned hepatitis C, which is a very actually important one. And for some reason is very diffuse lichen planus is associated with HIV. Okay, but hepatitis C is a very important one to remember. Now, what do I describe this change over here? What do I call this? Sawtooth pattern. If I tell you sawtooth pattern in any of these skin lesions, just say lichen planus. Okay? But there's other things that is happening in this patient, okay, in this lesion. Firstly, what's happening to the granulosa cell layer? You'll have hypergranulosis. What's happening in the stratum corneum? There's hyperkeratosis. Okay? Hyperkeratosis, I think. It was in your transcript. He mentioned it. So I was like, okay. Then another thing, the sawtooth is basically this. You can see one, two, three, four, five, six, seven, eight, nine. It basically looks like a sawtooth pattern. Okay, the lymphocytes eat up in a sawtooth pattern, which comes to this. So you'll have interface dermatitis. That's number one. And then the lymphocytes go up to the epidermis and start to eat up the keratinocytes. And it forms this body. What do we call this body? Civat bodies, which are dying keratinocytes, apoptotic keratinocytes. Okay, civat bodies. This is seen in lichen planus. Okay, that's basically lichen planus. Is everything till now clear before I go to blistering diseases? Okay, so I'll explain blistering diseases. Then we'll take a break before I go into cancers, or I'll finish the cancers and then we'll go to a break because there's a lot of micro in this crash course. But anyways, we'll go now to blistering formation. Now, blisters formation, as I said, it affects two things. Okay, firstly, how do keratinocytes attach to each other? Desmosomes. How does the epidermis attach to the dermis? Hemidesmosomes. Okay, these are the two things. Anything affecting these two will form into a blister. Okay, first thing is the connections between the epidermal cells or the keratinocytes, which is desmosomes. Important part of desmosomes that I want you to remember is this thing, which is called desmoglein. So desmoglein, there's two types of it. Desmoglein 1 and desmoglein 3. Okay? You need to know somewhat of a difference, which is this. Desmoglein 1 will be located superficially more. Desmoglein 3 will be located deeper into the epidermis. Okay? Why is this important? Is if you have a disease that involves only desmoglein 1, then you'll have subcorneal blistering. Okay? If you have something that affects both desmoglein 1 and 3, then you'll have the rest of the layers affected, which is more deeper into the epidermis. So remember, desmoglein 1 and desmoglein 3. If I ask you right now, what disease affects both desmoglein 3 and 1? Pemphigus vulgaris. Good. What affects desmoglein 1 only? Pemphigus foliaceus. Good. Now, what happens to the cells when you affect the desmoglein? It separates. What do we call this again? Acantholysis. Good. That's basically the desmosomes aspect. The other aspect is affecting the hemidesmosomes. Now, the hemidesmosomes will anchor the epidermis to the dermis. That's it. Okay. Obviously, there's other things involved, other types of collagen, and we'll get to this later. But the most important thing that I want you to remember is the BPAG2. Okay, there's also BPAG1, but BPAG2 is more important. This BPAG2 is the main component of hemidesmosomes. If you really think about it, this is the epidermis, this is the dermis. What's between them? This BPAG2. If you have separation or cut or absent of BPAG or something affecting BPAG2, you'll have separation of the epidermis and dermis. That's what's affecting the hemidesmosome. What disease is associated with defect of hemidesmosome? Bullous pemphigoid. Good. Now we have these bullous diseases. Okay, and we'll talk about each one separately. What I want you to remember is bullous diseases will present to you as bulla, okay, which are vesicles, large vesicles, okay, blisters. Now, these blisters might be very tense or they might rupture. What's the difference? Think about it. Is if the blister involves the hemidesmosomes, what's going to be covering the entire blister? The entire epidermis. So if you really want to think about it, will it separate? Will it rupture? Will it be easy to rupture? Yes or no? No, because it has an entire epidermis covering it. However, if it's affecting desmosomes and you have acantholysis, is there really anything covering the blister? Not really, so it will be easily ruptured. Okay? That's how these two present out. Now, another thing is how would you want to diagnose blister diseases? Is it to a biopsy? And what do you do after you take a biopsy? Immunofluorescence. Okay? What do you check for in immunofluorescence? Immunoglobulins, which is IgG or something else, depending on the pathology. Good. So what is causing a lot of this blistering diseases is immunoglobulins. Okay? IgG affecting desmoglein or hemidesmosomes, BPAG2. These are the bullous diseases. Now I want you to differentiate the bullous diseases based on images. First of all, as first thing is this. If it affects the superficial layer desmosomes, what type of desmoglein is affected? One. It affects right above the basal layer. What desmoglein is affected? Three. So in this disease, which pemphigus is associated with desmoglein 1 only, which is subcorneal, foliaceous. What is associated with suprabasilar? More vulgaris. Good. Now, what if you have complete separation of the epidermis and dermis? This is pemphigoid, which is bullous pemphigoid. Good. Okay. What's defected here? Is it desmosomes or hemidesmosomes? Hemidesmosomes. Good. Now, if you have this patient, this first one, presenting to you with ruptured vesicles everywhere in the body and oral ulcers, what is this disease? Pemphigus vulgaris. Good. Okay. Now, let's just say you have this one bulla over here. Okay. What if I put pressure over here and this thing ruptures? The bulla ruptured, the vesicle ruptured. What is this sign called? Nikolsky sign. Nikolsky sign, if you have, for example, a blister right here, if I put pressure right next to it, this blister will rupture. Why? It's because, again, what is pemphigoid vulgaris? It's an autoimmune type 2 hypersensitivity, which is IgG, attacking desmosomes. Which part of desmosomes? Desmoglein 1 and 3. What will it cause to the cells? Acantholysis. The cells will separate. So is there actually is there a thick layer covering the bulla? No. So if you put any pressure next to it, it will rupture it. This is called Nikolsky positive sign. Okay? Because the bulla itself, the blister, is weak. It will easily rupture. Now, to differentiate this versus what this is this is going to present in an earlier state. So a patient in around their 40s to 60s. And very important is oral manifestations. Okay, they will have oral ulcers. These two are important points of it. How about over here? Yes, you'll have some ruptured vesicles here, but maybe ruptured, but you'll have tense vesicles, not vesicles, tense blisters, and without any oral manifestations. What is this? Bullous pemphigoid. Okay, which is the most common bullous disease. Bullous pemphigoid. Now, will Nikolsky sign be positive or negative? Negative. This is important. Okay? Negative. Now, if you do IgG, if you check for immunofluorescence, this IgG will bind to what? Hemidesmosomes, which is not D1, D3, hemidesmosomes in this patient, which is bullous pemphigoid. Hemidesmosome. Okay? Now, it's hemidesmosomes and specifically BPAG2. Okay? D1 and D3 is in pemphigus vulgaris. Okay? Now you take a sample of this pathology. Now you see this. What is this disease? Pemphigus vulgaris. What do we call this lesion dermatologically? Acantholysis. What do you see floating around? Acantholytic cells. Okay? This is pemphigus vulgaris. Okay? Again, this is suprabasilar. It does not, you can clearly tell that the basal membrane or the basal cell is still there. Hence, are hemidesmosomes affected? Yes or no? I keep repeating the same questions just to make everything stick. No. This affects desmoglein 1 and desmoglein 3. Okay? Again, if I put pressure right here, what will happen to this blister? Rupture. What do we call this? Nikolsky sign? Positive. Okay, good. Here, do you clearly tell the basal layer? Yes or no? No, it's over here. So all the blister, it's under the epidermis. So what is this disease? Bullous pemphigoid. If I apply pressure over here, will it rupture? No. Nikolsky sign? Negative. It's a tense blister. Okay? Now, the blister itself will be filled with inflammatory cells, and they always usually love to mention the cell is eosinophils. You'll see eosinophils there. Okay? Well, that's that. Now you have this lesion. What do you want to do next? Immunofluorescence. Good. Now, another thing is this is also called a tombstone appearance, okay, for bullous pemphigoid. If you see it, and in case it's described to you in a question, tombstone appearance, it's pemphigus. One thing I didn't mention about bullous pemphigoid, other than how it presents, is it's usually an elderly, usually above 60. Okay, that's also another hint in a question. Now you have this. This is immunofluorescence, which is IgG against something. What can you describe with this? Already you mentioned it, fishnet appearance. Okay. What is it affecting again? Desmosomes. Which ones? 1 and 3. Desmoglein 1 and 3. This is pemphigus vulgaris. Okay. Over here, it's a linear pattern. What do we call this? Or what is this disease? Bullous pemphigoid. Why is it linear? Where are hemidosomes located? Between the epidermis and the dermis. Will it be anywhere else? No. Here, desmosomes are everywhere because it's between cells. Hence, fishnet. This is linear. Bullous pemphigoid. Okay? Now, one last thing about these two bullous diseases is if you have a patient who is diagnosed with bullous pemphigoid, what can be associated with bullous pemphigoid? It's paraneoplastic pemphigus. Good. What cancer is typically associated with paraneoplastic pemphigus vulgaris? Lymphoma. Do you know what type? Non-Hodgkin's lymphoma. Excellent. Okay. So, in patients with non-Hodgkin's lymphoma, they can present to you as pemphigus vulgaris, which is severe, which is going to affect a lot of mucosal surfaces. This is in the case of a paraneoplastic syndrome, which is in the case of pemphigus vulgaris. Okay? This is just a fun fact to remember about it, just in case that they give you a patient with non-Hodgkin's lymphoma presenting to you with a bullous disease, think of pemphigus vulgaris. Obviously, you'll see severe oral and the features of pemphigus vulgaris as well. Now you have this one, which is a very superficial blister or superficial erosion. And when you do histology, it's only affecting the superficial part of the epidermis. It's not affecting the suprabasilar part. This is pemphigus foliaceus, which is desmoglein 1 IgG antibodies against desmoglein 1, which is located subcorneal. Okay, this is the cornea right below it. Okay. Now you'll see also acantholysis. Okay, and you will see acantholytic cells, but not on this image itself, but you will see it. And when you do immunofluorescence, you'll see fishnet, but usually subcorneal. Okay, this is pemphigus foliaceus. Now you have this patient who is presenting to you with a long-term history of diarrhea that happens after they eat something, for example, wheat, and presenting to you with herpes-like rash and the extensor surfaces of elbows. What is this disease? Dermatitis herpetiformis. What is the underlying disease causing dermatitis herpetiformis? Celiac disease. Okay. What is celiac disease? Celiac disease is a GI disease. It's when you have hypersensitivity to gluten. Okay. And there's parts of gluten. It's mediated by IgA. Okay. So it's IgA against some parts of gluten. Okay. Which is gliadin or TTG or whatever. Anyways, what happens with these patients who have celiac disease is they have usually recurrent watery diarrhea. Okay. So with these patients with celiac, a common extra-intestinal manifestation is dermatitis herpetiformis. What is causing dermatitis herpetiformis is IgA, not IgG, affecting the dermal epidermal junction. IgA, deposition at the tips of the dermal papilla. Because a common question is how can I differentiate this versus bullous pemphigoid? The answer is bullous pemphigoid is IgG mediated. This one is IgA. They will tell you IgA, and they'll show you this picture. This is dermatitis herpetiformis. Remember IgA, and it's depositing at the tips of the dermal papilla. It's very similar, but they'll tell you it's IgA, and they'll tell you in the case this patient has celiac. And no, there's no herpes. It's just it looks like herpes. How does herpes actually look like? Small vesicles that form. It looks like herpes. That's why it's called dermatitis herpetiformis. Is dermatitis herpetiformis clear? How would you treat this patient? Avoid gluten. Done. Okay. And obviously, there's other stuff to it. It's not that easy, but usually, yes, mashallah. As you can use medication, the medication used is Dapsone. Good. Uh, Perfect. Now you have this inherited disease that's causing severe blister formation and rupture. The key word is inherited. Good. This is epidermolysis bullosa. Now, epidermolysis bullosa, keyword, it's an inherited disease, genetic disease. Okay, it's different than pemphigus from bullous pemphigoid, all the other types of pemphigus in terms of those were autoimmune. Okay, so usually these patients are a bit earlier, and usually there's something triggering it. What exactly? Don't know, but it's way more severe than pemphigus, and you'll see very severe separation. Number one is it's not acantholysis, as you can clearly tell over here, and it's usually below the epidermis. Okay, again, it's an inherited disease. Now, epidermolysis bullosa has multiple types. There's three types: simplex, junctional, and dystrophic. Okay, which affects multiple different parts. Okay. Now, epidermolysis bullosa simplex type affects the keratin 514. The junctional, which is the most important one and most dangerous one and more severe one, affects the interaction between these two, the alpha 6 beta 4 integrin and laminin 332. Why do I say that this is junctional? Is because this is the epidermis, this is the dermis. Between them, it's a junction. So, junctional type. And then you have the dystrophic type, which is going to affect type 4, type 7 collagen, sorry. Anyways, this disease, it's usually more severe. Okay, the patients would be very sick. Okay. I think the trigger here is medication that will trigger it. Uh, but yeah, it's more severe and it's an inherited defect in one of these lesions. If you use immunofluorescence, you won't see anything here. Okay. So this is epidermolysis bullosa. Why is you won't see anything in immunofluorescence? It's because it's not Ig mediated. It's a inherited defect in one of these structures. If it's simplex, it's keratin 514. If it's junctional, it's alpha 6 beta 4 integrin or laminin 332. Usually it's associated with this one. And lastly, if it's dystrophic, it's going to be type 7 collagen. Okay? That is epidermolysis bullosa. It's rare. It's more rare than the other ones that we talked about. Okay? Now, we will go into other diseases, okay, which is called panniculitis, which is inflammation of the subcutaneous fat, okay? Now you have these nodes that appeared on the lower extremities, okay? Again, on the extensor surface of the lower legs, okay? When you do histology, you see panniculitis, which is inflammation of the subcutaneous tissue, with no vasculitis. What is this? Yes, this is septal in this case. With no vasculitis, this is erythema nodosum. Good. Erythema nodosum is usually associated with systemic diseases. Again, medications can also cause this, and infections. Infections, again, you'll have mycoplasma as one of the main causes. Strep is another one. Then we have inflammatory diseases such as sarcoidosis, amyloidosis, IBD, very important. The IBD is very, very important, and it's usually Crohn's disease affecting it. And you have also certain medications that can form erythema nodosum. Okay. Now the thing about erythema nodosum you need to remember is it's septal panniculitis. It's affecting the septum over here, which is all of this between the fat cells and the subcutaneous tissue, and no vasculitis. No vasculitis. Okay? Why is this important for you? Is because you need to differentiate it with something else, which is this. If you have panniculitis with vasculitis, what is this called? Erythema indurate. These diseases typically affect the extensor surface, which is this, of the lower legs. Again, usually caused by something else. What's more common between these two? This one. Okay? And yes, we'll have ulceration. Good. Tamam. Now we can either have a break here because the rest of it is going to cancers. Do you want to take a break here, 5 minutes? Or do we keep going? Sure. So we'll return 8:48. 8:48 inshallah. Okay, so now we're gonna go into a lot of the tumors and melanin diseases. Okay, so firstly, we have these two diseases, not really diseases, but two findings of melanin. Okay, so firstly is here. What are we seeing here? These are just normal freckles. Okay, this is normal. Now, if you have a spread of melanocytes, which happens across the epidermal dermal layer, okay, or the basal layer of the epidermis, we call this lentiginous. So what do we call this? If it's just a spread of melanocytes? Lentigo. Okay? From the name, lentigo. It's just an area of hyperpigmentation, which is just melanocytes that are spreading lentiginously. Hence, we call it lentigo. Are these concerning? No. Are these that can this lead to cancer? Not really, no. Okay, these are just normal findings. Now we go into something very important, which is how do very malignant or pro-malignant melanocyte changes occur, okay? Which is in the context of melanoma. How do melanomas occur? The very important thing is remembering this pathway, okay? So the beginning of the pathway is mediated by RAS. Now, what does RAS do in general? You would have two different pathways that gets involved. One pathway is mediating the survival of the cell. Okay, the cell will survive. The other pathway is mediating the proliferation of the cell. So now how do cancers form? You either have increased proliferation or decreased cell death, which is cell survival. How do cells die? Apoptosis. Okay? So you will have an anti-apoptotic effect and a proliferation effect. What controls proliferation? Proto-oncogenes. If you remember from POD. Proto-oncogenes, which stimulate cell proliferation. Apoptosis, if you inhibit apoptosis, the cell will never die. It will survive. So in the context of melanoma, you have certain mutations and genes associated in both of these pathways. Now, the most commonly associated mutations that causes melanoma are what? There's two of them here. Which ones? BRAF, which is very important, and what's the other one? The first one. I know it says NRAS or KRAS, but RAS. Both of these. Now, there are other ones. Yes. So we have these tumor suppressor genes, if you want to call them that, such as P14, P16, and P10. Now, if you have a mutation that inhibits these, what will happen to survival and proliferation? Increase. Okay? So if you have a mutation that affects the tumor suppressor genes, such as P16, P14, P10, you'll have cell proliferation and cell survival. So what are the genes associated with melanoma or a malignant nevi, which is a mole? RAS or NRAS, BRAF, which is very important, high yield, P10, P16, which is very important. You also have P14, P53 as well, and CDK. Okay? Does this pathway make sense to you now? And why this is important in the context of a melanoma is if you have activating mutations of RAS, BRAF, CDK, then you'll have increased cell proliferation. If you have something inhibiting P10, a mutation inhibiting P10, P14, P16, you'll have increased survival and proliferation of a cell, hence causing a cancer. Okay? This is the pathologic pathway of a malignant nevi. Okay? Or a dysplastic nevi, anything that causes cancer. Now, what are nevi in general? They're moles. Okay? So moles is because of a proliferation of melanocytes. Okay? Now, melanocytes, when they proliferate, they form moles or nevi. Okay? Now, you have multiple types of nevi. If the nevi itself, or the mole, or the melanocytes are proliferating at the junction between the epidermis and dermis, what do we call this type of mole? Junctional. Why? Is because it's involving the junction. Okay? Now, what if the melanocytes are proliferating at the junction and goes into the dermis? What do we call this mole? Not complex. Compound. Okay? Compound mole. Now, what if the proliferation of the melanocytes are only in the dermis? What do we call this? From the name, dermal. Okay? Now, this, don't worry about it. Okay? But remember these terms. Is if I say junctional, meaning that the melanocytes are only proliferating at the basal layer of the epidermis, at the junction. If it's compound, then it's proliferating there and going into the dermis. And lastly, is if it's only in the dermis, then there. It's in the dermis. Now, are all moles neoplastic or a cause of cancer? No. Okay. There are certain ones that I'll tell you that are higher risk for developing a melanoma, which is a cancerous tumor of melanocytes. Okay. Now we have these. What are these? Just very simple. A lot of people have it. Nevi. Okay. Melanocytic nevi, moles. Okay. These are normal moles. Okay. How do I know that these are normal moles? Is it multiple things that you look into. Number one, is it symmetrical or asymmetric? Are the borders round or not? Okay, if it's round, it's good, which is the A, B, C, D, E, which we look into for a melanoma. Is the color all the same? Kind of, yes. Okay. The diameter, is it more than 6 millimeters? No. Okay, good. Is there invasion? No. خلاص. Okay, this is a normal melanocytic nevi, which is located, a lot of people, everyone has it. Okay? Now, we have some nevi that we want to identify. Okay, you need to know what these ones are. Now, what if a baby is born with a mole, a large mole like this? What do we call this mole? Congenital. Okay, congenital nevus. Good. What is this one? Intradermal. Okay, good. Now, why is it intradermal? Like, how can I tell that this is intradermal? Not gonna lie, I don't know. Okay, but just memorize this image. These images are just for memorization. Okay. How about this one? It looks blue. Blue nevi. How about this one? There's a halo around it. So we call it halo nevus. Good. Okay. Perfect. These images, memorize it for the sake of your asking. Okay. Now, if you have a baby that was born with this type of huge congenital nevi that has satellite formation, and then you do imaging and they have involvement of the meninges, you have a meningioma. What is this? This is very low yield, severely low yield. That may come. Okay, this is something that we call congenital nevomelanocytic nevus. Okay, that is affecting the meninges. Why is it affecting the meninges? Why is there a nevi in the meninges? Because, excellent. What is the embryological origin of melanocytes? Neural crest cells. What is the embryological origin of some layers of the meninges? What are meninges? It's basically the covering of the CNS. Okay, we have three layers: arachnoid, pia, and the dura mater. Okay, specifically the arachnoid and pia is from the neural crest, I think, if I remember. If you have a melanocyte that's from the neural crest forming a huge nevi, you might need to do a very huge nevi with satellite formation, which is basically small chunks of the nevi forming outside of the huge congenital nevus, which are all of these like small pieces. Then you need to do an MRI to check for meningeal involvement. How rare is this? Very, okay, but something one of the clinical doctors stressed on. So know it in case it comes. Okay, huge congenital nevus with satellite formation. You do an MRI to check for meningeal involvement. Okay, again, this is in congenital nevi, not in all types of nevi. Okay, now over here we have two types of nevi that you need to identify. This one is only involving this. So what do we call this type of nevi? Junction. Good. This nevi is a junctional nevi. Now, what if it's involving the junction plus the dermis? It's going into the dermis. This is a compound nevi. Okay? If it's only involving the dermis without the junction, what do we call this? Without the epidermis at all. What do we call this? Dermal. Good. And as one of you mentioned, is that the skin will be raised. Okay, obviously this one is, but it's like proliferating outwards, such as in the image that I showed you over here. Okay, but anyways. Now, these nevi are not always dysplastic or neoplastic. The dysplastic ones are somewhat like this. What is this nevi called? I gave you a hint already. This is a dysplastic nevi. Okay. Now, how do you know that this is dysplastic nevi? Is from the histological features. Okay. Here in the normal nevi, okay, or non-dysplastic, non-neoplastic nevi, is you have normal just aggregation of melanocytes, okay, proliferation of melanocytes. If these melanocytes start to form dysplastic changes, such as low such as an increased what's it called, nucleus size and stuff like that, then this is what we call a dysplastic nevi. Now here you have melanocytes, obviously, firstly, spreading lentiginously, which is through the epidermis, and then you'll have other dysplastic changes and a foci of, or a focus of, a nest basically of melanocytes forming inside the epidermis. This is a dysplastic nevi. The dangerous thing about a dysplastic nevi is that it might progress into a melanoma. Okay? It's starting to show dysplastic changes in the epidermis. Okay? Which might lead to this. What is this? Melanoma. Now, you're going to tell me exactly why this is a melanoma. Firstly, is it symmetrical or not? Asymmetric. Okay, this side is not the same as that. Good. Now, what is B? We're gonna go A, B, C, D, E. What is B? Borders. Is it regular or irregular? Irregular. What is C? Color. The lesion itself will have multiple parts that are different color. This is very dark brown, this is light. Okay? Multiple different colors. Okay? Some will also show as red. What is D? Diameter more than 6 millimeters. Excellent. If it's more than 6 millimeters, this is bad. This is a sign of uh, melanoma. Lastly is evolution. What does that mean? Changing over time. The skin lesion itself is changing over time and it grows. How is it changing? Is these areas, these darker areas are proliferating. Okay? And it's not going to stay as this dark. It's going to go to the lighter color later on. Less proliferation. It's just going to change because of the rate of proliferation. If there's more proliferation, then it's dark. Okay? So that is basically that. And another thing is we can actually track the treatment by this exact mechanism, which is the evolution. If we start treating this melanoma, if we don't excise it, for some reason we don't excise it, then it's going to change color to this lighter color if we give some sort of treatment, okay, such as a BRAF inhibitor, okay? This is melanoma, and you guys already mentioned all of these, okay? Good. Now, melanoma itself, we have a lot of prognostic factors about the melanoma. That's very important for you to remember. What is the most important prognostic factor about the melanoma? That's good. Breslow's thickness. Okay. What is Breslow's thickness? Is it horizontal growth of the melanoma or vertical? Vertical. If the melanoma is growing horizontally, which is lentiginous spreading of the melanoma, these are the malignant melanocytes, it's fine. It's better than this. If it starts to grow vertically, then that's bad. Very bad. Okay? That's one thing that will tell you about melanoma, and it could metastasize, so it's excellent. That's one prognostic factor. Other than that, there's multiple types of melanoma. So one of the types is increased in vertical thickness, hence why it's poorer prognosis. Also the size, and I think also the site, yes, excellent, of the melanoma and the gender. Okay. But the most important thing, which is a common MCQ question, is what is the most important prognostic factor? Breslow's thickness, vertical growth of the melanoma. This is the worst thing to see. Okay. Now over here, again, this is easy. What's it called? Melanoma. Okay. You'll see malignant melanocytes invading the basement membrane, and you can see a bunch of it over here. Okay. Now, again, well, how do you want to stain it to better see the malignant melanocyte? What do you use to stain it? S100. There's another one. Do you guys know what it is? Melanin A. There's a third one. HMB 45. Excellent. Good. Okay. HMB 45, melanin A, and you have also the most important one, S100. Usually they'll explain it, they'll tell you it as S100 lesion. Okay. S100 positive lesion. Okay. Good. Now, do we have multiple types of melanomas? Yes. What is the most common variant of melanoma? What do we call it? Excellent. Superficial spreading, which is basically like this type of melanoma. It's spreading superficially, okay? Horizontally, which is good, better prognosis or worse prognosis? Better. Okay, here we use a stain, okay, in this image. This stain is called S100 stain, which targets melanocytes. So if you see this melanocytes, which is deep into dermis, this tells you that this is a malignant melanoma. Is that clear? The purple one, this one. This is also another stain to melanocytes, and it's just showing you that it's invading the base of the basal membrane. I don't know which one you're talking about. Anyways, I'll get to it later, and inshallah after the recording. Okay, top right. This image. Anyways, I'll get to it later, so we can finish everything. Then I'll come back to it. Tamam. So, anyways, back to my question. And we have multiple types. We already said superficial spreading, which is the most common. Now, what is a variant that is most common in African American patients? Acral lentiginous. Where does acral lentiginous form? Typically, where in the body? Nails and the palms and soles. Excellent. Good. This is basically that. All I want you to remember, which they will always ask you, or a commonly asked question, is this. What is the most common melanoma in dark skin and Asian individuals, African Americans? Nail bed, or you can say the acral lentiginous one. Now, which one has the worst prognosis? Nodular melanoma. Why? Is because it has very fast vertical spreading. Okay? That's basically this. And superficial spreading, as I mentioned to you, is the most common one. That's basically the melanoma subtypes. Now, how do you treat melanoma? It's you firstly you remove the melanoma. Okay, you do wide excision, and then you also use uh, BRAF inhibitors. Okay, but the treatment you don't really need to know or worry about. Now you have this. We are done with melanoma. We'll go to this, and whoever had the question, I'll answer inshallah later. Is what is this? This is a patient presenting to you with a velvet stuck-on appearance lesion that is oval shaped. This is a key description of seborrheic keratosis. Okay, or seborrheic keratosis. Okay. Now, if it's multiple seborrheic keratoses, this is what we call a lesser trilate sign. What is this indicating to you? If you have lesser trilate sign is GI adenocarcinoma, malignancy. Excellent. Okay, usually GI cancer. Okay, good. Now, what do you see on histology? Is you have these cysts. What do we call these cysts? This one. Pseudocyst or horn cyst. Okay, this is a horn cyst. What is this, which is going into the epidermis? Another cyst, which is all keratin. Invagination cyst. Okay? Why is it invaginating? It's going into the epidermis. All of this keratin. Hence, this is what we call invagination cyst. This is a horn cyst. Okay? Again, the way that they always describe it to you is a stuck-on velvet-like lesion. Okay? This is seborrheic keratosis. Is there a specific receptor associated with seborrheic keratosis? I say receptor or gene associated. Just remember FGFR3. Okay? Remember it in case it comes. Now you have a patient with diabetes presenting to you with this. FGFR3, it's both. It's more associated with achondroplasia. Uh, Yeah, you have a diabetic patient that came to you with this lesion that's located either in the axilla or the neck, and it's described to you as a velvet lesion. Acanthosis nigricans. Good. Acanthosis nigricans usually occurs due to insulin resistance. Okay, in states of insulin resistance, as a very common finding in diabetes or any state that causes insulin resistance. Okay, now this is basically, I don't want to say benign, but this is the benign version of it. However, if you see an acanthosis nigricans in a patient who does not have diabetes or any insulin resistance risk factor, what do we look for? Not Cushing's. Again, Cushing's will cause insulin resistance. Cancer. Again, GI cancer. Okay? GI adenocarcinoma is associated with, firstly, the seborrheic, many seborrheic keratoses, the lesser trilate sign, and acanthosis nigricans. But however, usually in cases, they describe it to you as a diabetic patient. Okay? Or a patient with insulin resistance or pre-diabetes. This is acanthosis nigricans. What's happening in this? Just describe to me the lesion quickly. What do we call this lesion? Hills and valleys. Good. These are the hills. These are the valleys going down. Okay. This is acanthosis nigricans in a nutshell. Again, it's associated with insulin resistance. Now we have these lesions that affect the neck, a lot of areas. What are these lesions? Don't tell me the virus. What is this lesion? Warts, which is also what we call. Describe to me this histologic feature. Again, polyp. Good. Fibroepithelial polyp. Again, what's in the center of fibroepithelial polyp? Or a fibrovascular core. Good. Good. This is a fibroepithelial polyp or a wart, which is a very common finding in a lot of things. Okay, it can happen on its own. It can happen due to other diseases, and if it's affecting or if it's caused by a virus, such as HPV, this is what we call a verruca. Okay, do we need to know this? No, we'll talk about this inshallah in repro for 30 years. Okay, but just identify a fibroepithelial polyp. Just identify the image. That's it. Now we have a pre-neoplastic lesion. This patient has been in the sun for a very long time and presenting to you with this dry, scaly lesions on the forehead and sun-exposed areas. What is this? This is actinic keratosis. Good. Actinic keratosis. What will you see here? Some dysplastic changes occurring in the epithelium. That's number one. And do you see nuclei in the stratum corneum? So what do we call this? Parakeratosis. Good. So actinic keratosis is a risk factor for what type of cancer? Squamous cell carcinoma. Good. It's a precursor for squamous cell carcinoma. Now, usually a lot of times that this actinic keratosis can regress. It can just regress on its own and not develop into squamous cell carcinoma. Okay? Now, if it developed into squamous cell carcinoma, it can first form as a squamous cell carcinoma in situ. If it's a squamous cell carcinoma in situ on the skin, what do we call this disease or this lesion? If you guys know. It's squamous cell carcinoma in situ, but there's a name for it. Do you guys know? Bowen's disease. Okay? Excellent. Bowen's disease. Bowen's disease is squamous cell carcinoma in situ. What does in situ mean? It did not invade what? The basement membrane. If it invades the basement membrane, this is full-blown squamous cell carcinoma. Now you have a risk factor for squamous cell carcinoma, which is in the mouth. What is this white lesion in the mouth that if I try to scrape off, does not come out? Third years who took head and neck. Leukoplakia. Good. Okay. Leukoplakia. It's a risk factor for oral squamous cell carcinoma. Okay, good. Now, what if the patient developed this ulcer on the skin exposed area, such as the forehead, usually in the forehead, and you take biopsy and you see invasion of the basement membrane, and then you see this and this. What is this? Squamous cell carcinoma. Now, what do we call this lesion? Keratin pearls. Good. If you see keratin pearls in all systems, usually you'll see squamous cell carcinoma. A lot of blocks, you'll see squamous cell carcinoma. The way you can tell this is squamous cell carcinoma is keratin pearls. So you see keratin pearls, squamous cell carcinoma. Okay. Why? Is because it's a cancer of keratinocytes. Okay. That's it. Obviously, it's of squamous cells, but in the context of the skin, it's keratin. So keratin pearls. Now over here is something called intracellular bridges, which is desmosome. Okay, it's another finding of squamous cell carcinoma. How do you want to manage this patient? Firstly, you want to diagnose it, which you take a biopsy. And the way you take a biopsy, I don't know if it's important for you, if the clinical went into detail with it, but you just take wide excision of the lesion and then you send it to biopsy. Okay, this is squamous cell carcinoma. Is this the most common cancer of the skin? Yes or no? No. What is the most common? Basal cell carcinoma. Good. Now, what are risk factors for squamous cell carcinoma? Squamous cell carcinoma can occur because most commonly, sun exposure. Other than that, smoking, immunosuppression, and usually immunosuppression, like targeted immunosuppression to the skin. Okay. Arsenic can cause it. And genetic diseases, such as xeroderma pigmentosa, or chronic inflammation in the skin, such as what? Disease that we already covered. Not psoriasis. Lichen planus. Good. Okay. Lichen planus. Okay. And then in repro, you learn about other skin diseases such as lichen sclerosus, lichen simplex chronicus, all these lichen diseases, which are chronic inflammatory diseases of the skin. Okay. Can cause it. Okay. Good. Now, also, you need to know that there is a specific tumor suppressor gene, which is what that's associated with squamous cell carcinoma. Tumor suppressor gene, squamous cell carcinoma, not melanoma, squamous cell, P53. Now, P53 is between which two phases? G1 and S phase, excellent. So it's between G1 and S phase, and it's basically checking if there's any mutations. It shuts down that pathway. It's a tumor suppressor gene, okay? Over here, checkpoint. If you surpass this because of inhibition of P53 or absence of P53, you'll have proliferation, continuous proliferation of the cell cycle. So anything that is mutated over here can bypass P53 because it's there. It's not functional. Okay. So P53, remember it in squamous cell carcinoma. Good. Now you have one form of squamous cell carcinoma, which is a well-differentiated form, which is this. What is this form of well-differentiated squamous cell carcinoma? This is keratoacanthoma. Good. How do we describe this on histology? What does it look like? A volcano. Okay. Here it looks umbilicated. Basically, there's a central dimpling in internal dimpling of the lesion. Okay. And it's a well-differentiated squamous cell carcinoma. It's still a squamous cell carcinoma. And it usually sometimes regresses on its own. Okay. Here is all the epithelial cells basically surrounding the keratinocytes. Okay, or the keratin. Okay. Hence why it's a volcano-like appearance. So this is keratoacanthoma. Now you have this patient who's presenting to you with this pearly lesion that has telangiectasias. What is this tumor? Basal cell carcinoma. Excellent. What is the most common tumor of the skin? Cancer of the skin? Basal cell carcinoma. Good. Which of these two cancers, squamous cell versus basal cell, appear mostly on the upper lip? Basal cell carcinoma. Basal. Which one affects the lower lip? Squamous. Okay, good. On what is the most important risk factor causing basal cell carcinoma? Sun. Okay, sun exposure. Good. The lesion, grossly, will look like a pearl-like lesion with telangiectasias, which are blood vessels. Okay, these spider-like blood vessels. Okay, that's basically how it looks like. When you take histology or biopsy and histopathology, you can see basal cells invading the basement membrane. All of these collection of basal cells. Very important is this. This is what we call pseudopalisading, which is basically all these cells are basically arranged in parallel. Okay. And you'll have retraction of the basal membrane. Why does this happen? I'm not too sure. However, this is a very high yield image to remember. Okay. This is basal cell carcinoma. Yes, they are inside the dermis. They spread in deep into the dermis. This is the epidermis. It's spread inside. Okay. This is basal cell carcinoma. Now, how does basal cell carcinoma occur? Firstly, the most commonly is sun exposure. Now, you also have other genetic predispositions for basal cell carcinoma, which is inactivating genes, or sorry, activating genes of PTCH. Now, what is PTCH? You have this ligand, which is called sonic hedgehog, binding to the PTCH. When you have this ligand binding to PTCH, this causes dissociation of SMO. What will SMO do? Simulate gene expression, okay, transcription. Now, what happens if you have a mutated PTCH that does no longer need a sonic hedgehog? This will keep on activating SMO, hence causing gene transcription, gene expression, and you'll have unregulated cell division. So what is the gene affected here? PTCH. Okay. So if I ask you, what is the gene associated, most common gene associated melanoma, what is it? BRAF. Okay. Other ones are, for example, BRAF, RAS, P16, CDKN4 or whatever, and some others. If I ask you in squamous cell carcinoma, what's the tumor suppressor gene that's inactivated? P53 in squamous cell carcinoma, squamous. Okay. In basal cell, it's PTCH. Okay. Now, there are autosomal dominant genetic predisposition syndromes that causes BCC, which is this one. What is this called? This one on the, not this one, this one. Again, very low yield, but it's in your clinical and path lecture. Covering all bases just to make sure. But this is what we call Gorlin syndrome. It's an autosomal dominant activating mutation to PTCH, hence predisposing patients to basal cell carcinoma. Okay? This is Gorlin syndrome. What is this syndrome? They go into the sun and complete destruction of the cells. Xeroderma pigmentosum, good, which affects the nucleotide excision pathways, okay? And this basically predisposes to, what's it called? To UV light damage to cells without getting, basically fixing the nucleotide. So, in basal cell carcinoma, the most important risk factor is sun exposure. Now, you have certain genes that are mutated that will accelerate this process of the sun damaging the cells. Number one is Gordon syndrome. Okay? Gordon syndrome is causing activated or mutated PTCH. What will mutated PTCH do? It will cause SMO to be continuously active. It will basically no longer need this ligand to bind to it anymore. Okay? So more active PTCH or mutated active PTCH will keep activating SMO, and this SMO will cause more gene expression. Hence, abnormal growth. The cell division will no longer stop. Okay? This is in the case of Gorlin syndrome. But if I ask you if there's a gene mutated in basal cell or causing basal cell, what is it? PTCH. Answer PTCH. There's another syndrome or disease causing basically increased damage to sun, which causes both squamous cell and basal cell, which is dermapigmentosa. Okay? Usually they're describing to you, okay, Gorlin syndrome is causing basal cell carcinoma. Okay, it's severe basal cell carcinoma. Okay, because it's going to accelerate their sun-induced skin damage, which is causing all the mutations or the cancer. Okay, is this clear before I move on? And yes, it's autosomal dominant. Okay, now some other diseases before we go into infectious causes, which is going to be inshallah rapid, a lot of just quick answering and high yield tips to remember, is firstly alopecia. Alopecia, the most common type of alopecia is androgenetic alopecia. What hormone is causing the androgenetic alopecia? Hormone. Androgens. Which one specifically? More specific. Dihydrotestosterone. Dihydrotestosterone. Good. So increased dihydrotestosterone will cause this type of hair loss. Okay? Which is called androgenetic alopecia, which is most common. And it usually causes the pattern of hair loss starts from the hairline and goes posteriorly or from here. Okay? From the back. Now, how do you want to treat this? You can give minoxidil or teriparatide, which basically will inhibit the 5-alpha reductase in this level, which would basically decrease dihydrotestosterone. Okay? Or you inhibit dihydrotestosterone receptors. Will you get access? I doubt it. Okay? Now, there's another form of alopecia, which is called alopecia areata. Okay? This causes multiple foci of hair loss. Okay? And another thing is that you will not see any hair follicles in these areas. There's also another way to describe it, but I keep forgetting it. But basically, there's also another form of alopecia, which is if the patient themselves pull on their hair. So you'll see hair of multiple different levels because they're just pulling it. Okay. This is a psychiatric disease. In this case, yes, I think it's trichomoniasis. No, not trichomoniasis. I forgot the name. Trichotillomania. Good. Good. In alopecia areata, there will no longer be any hair follicles here. Okay, so they're not pulling it. It's just there's just nothing here. Okay. Now this will regrow on its own and it's relapsing for these patients. The way you treat it, it's not minoxidil, it's not anti-dihydrotestosterone, none of that. You give them intralesional steroids. Okay. Do you need to know that? I doubt it. But just recognize this type of hair loss. Recognize this and this in case it comes. Again, low yield for the exam, however, it might come. Okay. Now we will go to the skin infections. Okay. Everything till now, is it clear? Before I move on to skin infections, which will be very rapid, inshallah. Good. Now we start going through these infections. Now this child is developing a honey-crusted lesion. What is this? Impetigo. Good. Now, impetigo, there's two types. Non-bullous, bullous. What is the most common organism with both? Most common organism causing impetigo. The answer is Staph aureus. Remember Staph aureus. I know non-bullous impetigo is associated with strep pyogenes, which is usually what I would put. However, Staph aureus is still the most common organism for both non-bullous and bullous impetigo. Okay? Bullous impetigo, strep pyogenes cannot cause bullous impetigo. It's usually Staph aureus. Okay? How is impetigo happening? Or how does it present as? Very characteristic honey-crusted lesions in a child. Usually it's a child, and it affects around the mouth. Okay? This is impetigo. Again, what's the most common organism associated with it? I want you to answer Staph aureus. If they ask you bullous impetigo, Staph aureus always. However, in non-bullous, it's both Staph aureus and Strep. However, in total, all of them is Staph aureus. Okay? Confusing concept, and just memorize the most common organs associated with both of them is Staph aureus. Okay? Now, what are the difference between them? For your first one, first organism, what is this one? We covered it yesterday, so it should be quick. Staph aureus, which is gram-positive or gram-negative? Positive. Okay, good. And is it in cocci or cluster? Sorry, is it a cocci or a bacilli? Cocci or bacilli? Cocci. Is it in cluster or chains? Clusters. Good. This one, what is this organism? Strep pyogenes, which is a gram-positive cocci in chain or cluster? Chains. Good. How else would you differentiate them? Which one is, how else would you want to differentiate them biochemically? Coagulase and catalase. Catalase, we'll start with that. This is positive catalase. This is negative. Strep is catalase negative. This one, Staph aureus is coagulase positive. The other Staph spheres are coagulase negative. Good. That's basically that. Now, how about this? This is a baby presenting to you with this very severe lesion that has black necrotic areas and pus. This is what we call ecthyma gangrenosum. What is the most common organism associated with ecthyma gangrenosum? Pseudomonas. Good. A lot of these, you just need to recognize the disease, which is these lesions that have also pus from it and black necrotic areas. Okay, this is ecthyma gangrenosum. They'll ask you what is the most common organism associated with it? Pseudomonas. How can I tell this is Pseudomonas? Green. Good. How about here? This is a cutaneous abscess. Abscess is a collection of pus. Okay. What's the most common organism associated with a cutaneous abscess? It could be strep and staph, and it's usually staph. Okay. Now, how do you want to manage it? If you give antibiotics, is that enough? Yes or no? No. How do you want to drain it? Surgically, which is you just make a cut like this and you remove the pus and then you give the antibiotics. Okay. That is basically a cutaneous abscess. Okay. Now, would you want to use or can you use an imaging modality to diagnose cutaneous abscess other than taking culture from it and stuff? Yes. What imaging modality would you want to use if you want to use it to see an abscess? Ultrasound. Okay. Ultrasound. MRI is for deeper tissue, but however, this is cutaneous. It's right here. So you're just using an ultrasound. Okay. So that's basically that. Now we have two diseases. We have this infectious skin disease that is well demarcated. What is this called? Erysipelas. What is the organism causing erysipelas? Another one, strep. Strep pyogenes. Strep. Okay. Strep causes strep pyogenes causes erysipelas. Okay. More associated than staph. In cellulitis, it's A number one, not well demarcated. You cannot tell the difference. Why? Is this is a bit, this is more deeper than this. This involves a deeper dermis more than the erysipelas. Okay. Uh, so it's not well demarcated, and it's usually associated with staph infection. Okay. This is cellulitis. This is erysipelas. Okay. Exactly. This one is gonna be well demarcated. This is usually how they tell you in the question. Well demarcated borders, erysipelas. Cellulitis is with staph usually, and it's gonna be diffuse. You cannot pinpoint where. Okay. Clinically, how will they present? Both of them will fever, pain at this area, erythema, swelling of this area. Both of them will present the same. However, when you look at the skin lesion, the most important demarcation point is the borders. Okay. Okay. Now you have this infection that firstly presenting to you as a painless genital ulcer that later developed into diffuse rash. What is this disease? Syphilis. Good. Syphilis is caused by what organism? Treponema pallidum. Is it gram-positive or negative? Negative. Good. It's a spirochete. Perfect. Or a spiral organism. Now, how do you want to diagnose it after you take it? Is using this, which is called dark field microscopy. Good. Now, syphilis has three stages. Primary, secondary, tertiary syphilis. This is something you will learn in detail in repro, inshallah. You'll need to differentiate between primary, secondary, and tertiary syphilis. Usually, how they present with primary is a painless genital ulcer. Okay, and this differentiates syphilis with other causes of genital ulcers. Okay, if it disseminates, it causes diffuse rash. Okay, which is secondary form of syphilis. If this syphilis does not get treated, the secondary, later on it forms tertiary syphilis, which has neurologic deficits and cardiovascular deficits. Neurologically, tabes dorsalis, which affects the dorsal column tract. Inshallah, for second years, you'll learn this in neuro. And cardiovascularly, it can cause aortic diseases. Okay? So that is basically syphilis in a nutshell. Again, don't need to know the details of primary, secondary, tertiary. So remember, primary is here, painless ulcer. Secondary is diffuse. How do you diagnose it? Dark field microscopy. Okay, syphilis. Now, if you have inflammation happening at the hair follicle, what do we call this? Infection of the hair follicle, folliculitis. What if it's spread deeper? What do we call this? Furuncle. And what if it fuses together and has a lot of pus? Carbuncle. Good. Good. Now, what is the most common organism causing all three of these? Staph aureus. Now, there's something called bathtub folliculitis. What organism associated with bathtub folliculitis, which is water-based? Okay, someone who went swimming or in a bathtub, literally, and then developed folliculitis. This is Pseudomonas. Good. It's usually described to you as bathtub folliculitis. Okay. But anyways, folliculitis is infection of the hair follicles itself. If it increases in size and goes deeper, this is a furuncle. If it joins together with other furuncles, this is a carbuncle, which is a larger furuncle. Okay. Again, most common organism, Staph aureus. Tamam. Now, you have a patient who had a very severe bleeding from the nose, and you packed it. Later on, developed with this. What is happening here? Staphylococcal scalded skin syndrome. Good. What's the organism that causes it? From the name, Staph aureus. Okay. Now, what's happening with this is exotoxin that is going to go and damage, hint, hint, desmosomes. Good. And this will cause acantholysis and whatnot. MashaAllah, you're predicting my questions in the future. Okay. But anyways, why no bulla? You answer me. As if it's acantholysis affecting usually desmoglein 1. So what's happening with the bulla? Rupture. They rupture. Okay. So exotoxins are usually damaging desmoglein 1 more. So they're gonna affect and cause rupture of the skin. Okay, and the skin will fall. Okay. So that's that. Okay, this is Staphylococcus called it skin syndrome. Okay. Now we have viral skin infections. So we have this oral ulcers, cold sores is another name. What do we call this? HSV1. Good. HSV1 usually affects oral. Okay. HSV2, where does it affect usually? Genital. Good. What type of virus is HSV? DNA. Single-stranded, double-stranded, what? Double-stranded DNA. Good. Now HSV1, once a patient is affected with HSV1, it is lifelong. Okay. How does it happen? Is when you have this infection, this HSV1 will go to the dorsal root ganglion and will be latent there. Upon stress, upon whatever, infection, immunosuppression, whatever, usually it's stress, these lesions will develop again. Okay. Uh, but this is basically HSV1. Now, HSV1 can cause a lot of other complications. Okay. And we'll talk about, actually, we won't talk about this, but basically it can affect neurologically and stuff like that. But don't worry about it. Just identify this as cold sores, HSV1, double-stranded DNA. Okay. Now, how about this baby who was not vaccinated? Chickenpox, good. Which is caused by what organism? Varicella zoster virus. Good. So varicella zoster virus will cause these lesions, vesicles, to form everywhere in the body for a child. It's very good, if like not good, but like it has very good prognosis in children. However, if varicella chickenpox happens in adults, it's bad. It causes encephalitis, mashallah. Okay, and pulmonary disease. Okay, but yeah, you have varicella zoster. We have a vaccine for it. Easy. Okay, now. If this varicella zoster remains latent, it can activate later on in adults and it affects this. What do we call this? Shingles. What if it affects the first cranial nerve? What do we call this? Herpes zoster ophthalmicus. Good. Now, just to go back to this point, is varicella zoster, the infection itself, chickenpox, in children, it has good prognosis. It will resolve on its own. You just treat the patient. In adults, it's more severe. You need to treat them with antivirals. Okay? You need to treat them in with antivirals for varicella zoster. Okay? Because it might develop into encephalitis and pulmonary disease. Okay? No problem. Here, if you have reactivation of a varicella zoster, the patient already had the chickenpox as a child. Later on, with immunosuppression, or they're taking, for example, steroids, and they develop this dermatomal rash that may affect usually in the trunk, or the distribution of the first trigeminal nerve, which is V1. This is what we call shingles here. Here we call herpes zoster ophthalmicus, which may lead to simply it affects this area, so blindness. Okay. Yes, we treat it with antiviral. And what antiviral do you want to use? Acyclovir, good. We'll talk about these medications in a bit. Now you have an immunosuppressed patient, more specifically has HIV. And develop these purple verrucous lesions. Kaposi sarcoma, good. Caused by what infectious organism, usually? HHV8, human herpes virus 8. Good. Now, important thing is you need to identify one thing histologically or histopathologic. How do we characterize these lesions? What do we say these cells look like? Spindle-shaped cells. Good. Okay. In a nutshell, Kaposi sarcoma is a tumor that happens in HIV patients, usually with CD4 count, very low CD4 count, below 200. And it's caused by HHV8. Okay. And in histopathology, we see spindle-shaped cells. Okay. This is Kaposi sarcoma. Now you have this infection, which came up very recently, again, like spiked, that affects usually the palms and soles. This is monkeypox. Good. Okay. Usually affects the palms and soles. Okay. Good. Now we have this characteristic lesion, which is a umbilicated lesion. Okay, it's what do we call this? Molluscum contagiosum. Good. What type of virus is molluscum contagiosum? Pox virus. Good. What type of virus is the pox virus? DNA virus. And it has glycoproteins. Remember this. Okay? Why? Is because the other double-stranded DNA won't have this. This is just something that was asked before. Okay? In previous review sessions by Dr. Botta. So remember this. Okay? It's a DNA virus, and you need to memorize these lesions. Okay? This is usually a sexually transmitted disease and in adults usually. However, in children, it's seen, but it's not a sexually transmitted disease in children. Okay? But in adults, it is. That is molluscum contagiosum. How do you tell this? Is that you have the skin dimpling in the middle, this umbilicated lesion. This is a characteristic of molluscum contagiosum. Okay? And if it happens in child, anywhere in the skin, okay? There's no like specific location where they develop. In children, if it happens, what's it called? They just go away on its own. If it happens in adults, you treat them. Uh, but yeah, yes. Now you have this patient who is presenting to you with severe tonsillitis, which is inflammation of the tonsils, rash, and severe fever. This is what we call infectious mononucleosis, which is caused by what virus? Epstein-Barr virus. Okay. Infectious mononucleosis, which is also called Kissing's disease, is caused by Epstein-Barr virus most commonly. There's another virus that may cause it as well, which is called what? CMV, cytomegalovirus, rarely. Okay. This usually happens in teenagers, okay, and early adults. And it usually causes severe tonsillitis, a rash that develops, and severe fever, and usually also causes splenomegaly. Okay, this is infectious mononucleosis caused by EBV. CMV, the characteristic way I would tell you a CMV infection is in a immunosuppressed patient who developed a severe rash later. Okay, this is CMV. Again, CMV is an opportunistic virus. It happens usually in immunosuppressed patients. Either these are patients on chemotherapy, these are patients who have HIV, who later developed or has a low CD4 count. Okay, CMV happens in immunosuppressed patients. EBV mononucleosis or infectious mononucleosis happens in teenagers or early adults. Okay. CMV is usually described in an immunocompromised patient. Okay. These are these two viruses. Rosettes. I'm not sure for molluscum. I'm not sure what it looks like on histopath, but just remember this lesion. Okay. Now we have this patient who is presenting to you, who is an unvaccinated child, presenting to you with a rash that started in the face and moved all the way down to the palms and soles. Unvaccinated child. What is this? Measles. Perfect. And it's a maculopapular rash. Good, excellent. So measles. What is another name we give to this measles in children? This rash. Good. What is another name we give? We call it by numbers. So what is the number of this disease? First disease. Good. Okay, this is first disease, which is measles. How do they usually describe it to you as? Is this patient is unvaccinated, initially presented to you with cough and conjunctivitis. Okay. Sorry, not conjunctivitis. Cough and basically runny nose that later on, a few days later, developed into a rash that started in the face, then moved down. This is measles. They have usually a prodrome of symptoms, which is the C's, okay, which is cough, coryza, and some other stuff, okay? I think also conjunctivitis and complex spots in the mouth. This, I think you learn in more detail, or you did third years in CVP, and then for second years you'll learn in CVP. Okay, but this is measles. Again, presents with these symptoms initially, then later on develop this maculopapular rash, which started in the face, moved down. Okay, how do they tell you it? Is it's an unvaccinated child. Okay, this is measles. What type of virus is measles? RNA virus. Good, good. Now you have this. Okay, this patient is presenting to you with pharyngitis and has a sandpaper-like rash in the trunk and a strawberry tongue. What is this disease? Scarlet fever. What if I tell you this patient has strawberry tongue, conjunctivitis, severe fever, and edema of the hands and foot? What is this? Kawasaki. If it's a patient with pharyngitis, strawberry tongue, and a sandpaper-like rash in the trunk, this is scarlet fever, which is secondary disease. What is the infectious organism causing scarlet disease? Strep pyogenes. Good. That's it. It's second disease. Good. Now, what is this? Uh, this is a patient who's presenting you with a rash that started in the face, more specifically behind the ears, spreads downwards, but does not involve the hands and palms. This is rubella. Okay. This is third disease. Good. Now, high yield, very, is you have the slap cheek rash. What is this? What number of diseases, child diseases is this? Fifth disease. Good. What's another name for fifth disease? Ecthyma infectiosum. Okay. Or sorry, erythema infectiosum. Good. And it's usually caused by what virus? Parvovirus B19. Now, if you have a patient in utero infected with parvovirus B19, what happens to them? Anemia. What do we call this anemia? Aplastic anemia. If you remember for third years, if you remember from HLS, so heme onc, sorry, that I described to you is if you have a patient with aplastic anemia, what's one virus that can cause it? Parvovirus B19. Okay. And in utero, this usually causes hydrops fetalis, which is basically the baby will die in utero. Okay. This is parvovirus B19. What type of virus is it? DNA. I think it's DNA virus. Okay, the ones that are RNA that you want to remember are measles and rubella. Okay. Now, here we have third disease and fifth disease. What is fourth disease? Staphylococcus scalded skin syndrome. Good accent. Now, we have this patient who is immunocompromised or has diabetes who presents you with a rash that develops under skin folds. So, for example, either the axilla or the breast in females. Candida. What do we call this finding, which is a rash under the folded areas? Do you guys know? This is Candida, you're right, but there's a name to this because not all cases of this we call it, it's caused by Candida. This is what we call intertrigo, okay? It's basically infection that happens on the folded skin areas, okay? You don't need to go into detail with this. However, we have Candida. Candida usually happens in immunosuppressed patients, diabetics, patients taking glucocorticoids, and has many manifestations. If it affects the mouth, this is what we call oral thrush. Okay. Now, on a skin lesion in a patient with Candida, it's usually a white curd like lesion. Okay. Now, when you look at the fungus itself under a microscope, how do we describe this? Pseudo-hyphae. Good. Intertrigo. This intertrigo. Not impetigo. Oh, no. I think that's how you pronounce it. Okay. Now we have other fungal infections of the skin. We have tinea. Now, tinea, another name we want to give is cutaneous mycosis. Now, tinea is infection of dermatophytes. Okay. Now, dermatophytes, there's three types. There's microsporum, trichophyton, epidermophyton. They are branching septate hyphae, visible on KOH staining, which is very important for you to remember, is you need to do potassium hydroxide staining for patients with suspected tinea. Now, tinea itself has many manifestations, depending on the location. One of the more common locations is in the foot, which is what we call athlete's foot, which is tinea pedis. Now we have other manifestations such as tinea capitis, which affects the cap, so head, corporis, which is the body, cruris, which is the groin, and then we have tinea unguium or onychomycosis, which is in the nails. Okay. Now you need to just identify what these are. Firstly, is what is the organism causing tinea? Dermatophytes. This is dermatophytes. If it affects the scalp, what is this tinea infection called? Capitis. If it affects the body, trunk, what do we call it? Corporis. If it affects the groin, cruris. If it affects the foot, pedis. Or another name, which is the common name in general, athlete's foot. Good. And it's a very common one. And it's usually interdigital, which is between the toes. Okay. And what if it affects the nails? Unguium or onychomycosis. Good. Yeah. Good. Now, unlike Candida, this can happen in an immunocompetent patient. So, for example, tinea pedis is very common in athletes. Okay. Now, how can the rest of them form? Is if a patient had tinea pedis, itches this area, and then touches something else. The dermatophytes will go there. That's it. Okay. So if you have a patient with repeated, for example, tinea cruris presenting with repetitive rashes and whatnot, you need to check other areas of the skin just to see where the primary infection is, which is usually in the foot, which is commonly missed. Okay? This is just a fun fact for you guys. I don't know how important it is for your actual exam. Okay? But anyways, now you need to just identify the dermatophyte itself. As I said, you have microsporum, trichophytum, and epidermophyton, which is what is this one? Trichophyton. Good. What is this one? Club-like shaped microsporum. Good. That's it. Okay. Just know how to identify these in case it comes in, what's it called, in OSPE. Okay. Now you have a patient who was bit by a mosquito and later on presented with cutaneous lesions. What is this? Leishmaniasis. Good. What do I see here? What do I call this form of leishmania? Amastocoids. Where are they present? Inside the WBCs, inside the macrophages. Good. This is characteristic of leishmaniasis. And it's transmitted by the phlebotomous mosquito. Now, for leishmaniasis, we have multiple forms, two main forms, the cutaneous and the visceral leishmaniasis. What causes the visceral leishmaniasis? Donovani, just remember that one. Cutaneous is some other ones, okay? Which you can see here. Donovani causes visceral leishmaniasis, which affects the liver, spleen, and bone marrow. Okay? This is visceral leishmaniasis. Okay, good. Now you have a child presenting to you with severe itchiness that happens very badly at night. You do physical exam and you can see these linear burrows in the skin. What is this? Scabies. Good. What is What do we call this bug? It's scabies, but what is the actual name? Mites. What is the name of the mites? It's called sarcoptic scabii. Okay, something like that. Anyway, scabies. How does it present? This mite will go and burrow itself in the skin, okay, and cause inflammation. It's usually described as linear burrows in the skin. So it goes linearly, okay? Such as over here, it goes this way, okay? Usually affects the hand and especially interdigital, okay? Mostly in the hand. The pain is worsened at night, and it's usually affecting multiple people at once, especially if they live in the same dorm room, okay, or the same room. So how do you want to manage them? Firstly, is you clean them up, okay, and you move any of the clothing that might be affected and the bed sheet as well in case it's there, okay, and you give them specific medications, and we'll talk about them. Permethrin, excellent. Now you have this, which is affecting the hair, causing severe itchiness of the hair. What is this? Lice. What is the medical name of lice or this disease? This is called pediculosis. Okay, which is lice. How do you tell this mite is lice? It has 6 legs, apparently. Okay, I don't know. This one has multiple, this one has 6. So this is lice. Something from your micro lecture, I don't know. Now again, you treat this by cleaning the hair very well, and then you can give topical agents, which is permethrin. Okay. Now this one, I don't know if you guys will know it. I don't know if it was in your lectures. However, I brought it because it was there last year, and I did not see it this year somehow. And it's an important disease. But let's just say you didn't cover it this year. فخلاص at all. This is not Lyme. Okay, خلاص. Ignore the slide. Okay. But yeah, okay, ignore the slide. But basically, this is Rocky Mountain spotted fever. This is basically caused by rickettsia. It's a tick bite infection that affects the joints and usually causes rash in the palms and in the wrists, usually. Okay. And here it's in the legs. Okay. And causes arthritis, fever, and headaches. Ignore this disease. Now we have a patient who's presenting to you with its rickettsia, I guess. These findings: conjunctivitis, severe fever, strawberry tongue, and edema of the feet and hands. What is this disease? Kawasaki disease, which is a form of vasculitis. Okay, it's caused by immune dysfunction. Okay, this is Kawasaki disease. Is it an infectious cause? Yes or no? No. What if you have a patient who comes with strawberry tongue with pharyngitis and a rash over here in the trunk? What is this? Scarlet. So remember these two causes of strawberry tongue. Don't be confused by them. Okay. Now we go to the final thing of this crash course, which is the drugs used in skin diseases, skin infections. We have bacterial infections. The first line usually of a lot of these diseases is penicillin, which is fluoxetine. Okay. You need to remember this one very well. Now, if you have a acute localized impetigo, you can use this, okay? And if you have MRSA, we use Vanco, or second line is linezolid, okay? Viral infections, acyclovir is the first line and the one drug that you need to memorize for all these viral diseases. Fungal, we have azoles, we have clotrimazole or fluconazole, and then we have terbenafin, which is used for a lot of the tinea infections. Then we have for the parasitic infections, topical such as permethrin, which is the first line for all of these parasitic infections, such as scabies and lice. Okay, and if it didn't work, then we go to oral ivermectin. If it didn't work, okay. So we have the beta lactams. Penicillin is the first line, or this one if they have. It's usually this one is given first line, okay, for a lot of the skin infection by penicillin resistant organisms, okay, which is a lot of them nowadays. However, realistically, penicillin can be used first line for a lot of these infections, okay? However, if it's penicillin resistant, then we use this drug, okay? Except for MRSA. In the case of MRSA, what drugs we use? Vanco. What second line? Linezolid. Good. And we have all these other ones, but don't go into detail with the other macrolides that can be used. Then, as I said, acute localized small areas of impetigo, we use mupirocin or fusidic acid. Okay, just remember this one. Now, what it does, it binds to this bacterial tRNA synthase, inhibits protein and RNA synthesis. Now, for fungal infections, we use azoles or terbinafine. Okay, usually, we use them both for dermatophytes infection of the skin. And now for candida, we use azoles, okay, mainly. But for dermatophytes, we use both of them, fluconazole and terbinafine. Now, terbinafine, we specifically use it. I don't know if this was mentioned to you guys, but we specifically use it for the tinea unguium, which is the nail infection, okay, which is the onychomycosis. We use terbinafine. Now, what do? They inhibit fungal C14 alpha demethylase, which will just basically cause cell death. And then terbinafine, cell death again, by converting squalene to ergosterol. Squalene is toxic, okay? That's basically these drugs. Now, lice and scabies, just remember permethrin and these two drugs, lindane, and then you have ivermectin. First line is permethrin, which is neurotoxic because of it basically prolongs sodium channels, and this will cause what's it called? Respiratory paralysis in the parasites itself. Now, how do you use it for scabies? We just apply cream all over the body. For the case of lice, in the hair, okay? Now, we have other ones that can be used as well in case we can't use permethrin for any case, such as lindane, and then we have ivermectin. And ivermectin is also very effective, but however, it's an oral medication, so we give it if this doesn't work, okay? Now, with that, I am done with the crash course for MSI. Are there any questions in total? The things I did not cover, I'll tell you. I did not cover histology, which is the Dr. Annie stuff. And for that, there's the lab file for Dr. Annie, just cover that. Other things is, for example, Allah, I think, for the physiology, I covered some of them, like the clinical aspects of it last lecture. However, for the temperature regulation, just go through it. I think Dr. Shams taught you it. His questions are very easy from that lecture, inshallah, if he brings any. For us, I think he brought one. And then I'll answer your question in a bit. And then we have immuno. I mentioned already like some aspects for the skin diseases. For example, what type of hypersensitivity is contact dermatitis, allergic contact dermatitis type 4, pemphigus is type 2. And then we also have psoriasis, which is T helper 17 and T helper 1, which is the most high yield concepts in immuno for the skin diseases. But you also have the rheumatoid and SLE stuff, which I covered most yesterday. Right there in sports medicine, I recommend you guys just the before the exam by a bit, 2 days, 3 days, is just listen to the recording for Dr. Thamer. He loves to explain a lot in case I miss something. But other than that, inshallah, I tried to cover everything for you guys, and inshallah, this was helpful. And yeah, best of luck, inshallah.